Now I am starting the recording these sessions. Good afternoon to all. I am Dr. Aftab Hussain Mondal, Assistant Professor of Microbiology at Maulana Azad College. I warmly welcome you all to the second sessions. In this sessions, we are honored to begin with our first speaker, Dr. Ritik Ganguly. It is my pleasure to introduce Dr. Ritik Ganguly, sir. And he is an accomplished orthopedic surgeon, academician, and internationally trained specialist in arthroscopy and sports medicine. Currently, he is
Thank you.
serving as professor of orthopedics at KPC Medical College and Hospital, Kolkata. Sir has done his MBBS from North Bengal Medical College and MSc in Orthopedics from Medical College, Kolkata. Subsequently, DNV from National Board of Examination in 2014. Dr. Ganguly pursued prestigious international fellowship, including a fellowship in arthroscopy and sports surgery in Japan and fellowship in advanced shoulder surgery in France. He also a active member of the National Academy of Medical Sciences. He is an he is also an invited faculty at various national and international conferences. He has published many research articles in various reputed international journals. Dedicated to clinical excellence research and teaching, Dr. Ganguly continued to be a leading voice in advanced orthopedics and sports medicine practice in India. Today, he will deliver an insightful presentation on the cutting edge topics of medical engineering and robotics. Now, sir, kindly start your presentation.
Thank you. Thank you. This is an immense pleasure for me to be here in front of all of you about that this is a very nice course in the bioscience, bioengineering, and nanotechnology. And this is my first time to be here in the course, and I am very pleasure and it's a fortunate for me to be here in front of all the learned person. So uh, I can present this. This is uh, my presentation about the biomedical engineering and the robotics. And so, can you see my slides here?
Yes, sir. Yes.
Okay, okay. So biomedical engineering has changed the way of the treatment of the all the fields, the medical fields. There is a revolutionized change in the medical field by the biomedical engineering. And recently there has come the robotics, which has added a very good impact in the treatment. And it is not only the surgical part that robotic has its immense importance, but in the non-surgical part also, in the from the diagnosis, the
Excuse me, sir. Your screen is presenting that is open a Gmail. Kindly close it.
Yes, sir.
okay,
Only Gmail is there, sir. Your email is there, sir.
okay, okay. So Gmail. Okay. Gmail is sharing, so I can share. One second. So sharing.
Sir, if I may suggest, you may share the window and not the screen. Then your particular window will be shared.
Okay, so I have entered the shared screen. So
Kindly share the whole screen, sir.
yeah, shared screen, and that comes choose what to share the window. Okay, window,
Yes,
right?
yes, yes, sir.
Okay,
Right, sir, the particular window.
okay. Can it be seen?
Yes, sir. Now
Yes, sir.
it's
Okay,
visible.
okay. So Biomedical engineering has revolutionized the treatment of modern medicine. If we can see the treatment, we are today, it is a result of continuous effort, and there is a an effort, and there is a discovery by the biomedical engineers, so that we can go to that this stage, and this has changed the whole the treatment process in modern era. So the outline of our presentation is: first, the introduction to biomedical engineering and its importance in modern care; the engineers, role of the engineers in developing medical technology, the new technologies which are developing, these are sole product of the continuous effort of the engineers; the innovative approach in biomedical engineering for the patient. So these techniques are developing, but how these techniques are helpful for the patient, we can discuss this technique. Impact on patient involvement and health behavior, and the recent innovations and impact in healthcare devices, because previously we all know that before the 2000 era, there is very less gadgets, and this before this era the treatment was not that much of friendly to the patients have to go to the hospital, they can give a long queue, and after the long queue, his or her name has been announced to see the doctor. So there's a very simple example. If we want to check, you want to see a doctor, you can take the appointment in the online, and in the online basis your serial number is maintained. So, and your time slot has been given to you, and you can direct go to the timing slot to the doctor, and you can see the doctor. So this not only helps the patient care, but also improves the time factor of the patient and doctor in healthcare system. The telemedicine in patient monitoring, enhancing the care to the remote technologies.
Excuse me,
Because
sir. Sir, your slides are not moving.
yeah,
Are
yeah,
you on a second slide?
yeah. I am not moving. I am on the stick on the single slide, first slide.
Okay. Okay.
Okay, sir.
Yeah. So telemedicine is an immense role. Suppose the patient, now we have the different kind of jobs, the shifting duties, and in between the duties, it is very difficult to leave the duty and go to the appointment to the doctor. So the telemedicine has an immense importance, and if a patient is in a remote place from the doctor, suppose if you want to take the appointment of a Kolkata doctor, and patient is in Bangladesh or Dhaka, so he or she can help the telemedicine, so that he can do a good consultation with the proper doctor. The integrating robotics in surgical procedure, there is definitely the benefits of robotics. I am going into detail in that. The artificial intelligence for personalized patient care and organ transplant, the future of biomedical engineering and healthcare. So these are the outline of the today's presentation. So, introduction to the biomedical engineering in modern healthcare. So, it is normal question. So, it is a doctor or engineer or both. Okay. So, what is the key aspects of biomedical engineering? The biomedical engineering combines the engineering principle with the medical sciences. So, we have to keep in both. We have to know the medical sciences, the physiology, biochemistry, anatomy. Okay, everything you should know, and also you should know the basics of engineering for which we are going to plan. It develops the medical devices, imaging system, and diagnostic tools. Focuses on improving patient care and health outcomes. Integrates the technology into healthcare system. So it is not the separate thing. The healthcare system and technology is not the separate thing. So this is a conglomeration of the technology, good technology and healthcare system, so that the healthcare system become flawless, and it is very much accepted, well accepted by the patients and the families, and also by the caregivers like doctors and the hospital staffs. The supports It supports the innovation in medical research and treatment. So previously the research was not that much of it is a very slow process, but with the advent of this biomedical engineering different methods, this research become of very much active, very much the speed has been increased.
Excuse me, sir. We are
Yes.
in the same first slide. Are it
Yeah.
only first slide is visible?
Oh,
So
only
the slides are not moving actually.
Exactly.
okay.
Only the first slide can be seen.
Only the first slide is seen.
Yeah, sir, you can put in your PowerPoint mode. I think it will be better for us.
I have done in the PowerPoint mode.
So the slideshow mode, if you put on, then I think the slides will be visible.
So probably you need to probably click on the orange button in the bottom bar, sir.
I am not seeing any orange button. That's a problem.
The play symbol in the bottom bar.
Sir, I think F5 button will also lead to the presentation. Clicking F5 will also show the slides.
Sir, you are muted also.
কিছু বলছেন? হ্যালো? Yes.
Hello.
Yeah, we can hear you, sir.
Okay. So now I can share the window and actually it is very
Morning. হ্যালো স্যার। আচ্ছা স্যার, নোট আছে।
হ্যাঁ অভিজিৎ বল।
Hello, sir.
Yes, yes, I can hear. I can hear.
If it is possible, you can send us your PPT.
Yeah, I can send. Okay, okay. Yes, that's possible. That is possible.
Please send us the
Yeah,
PPT.
yeah.
We
I
will
am
take
right
it
now.
from there.
Right now, I am sending. Right now, I am doing. শোনো না খুব ঝামেলায় পড়ে গেছি বুঝলে?
হ্যাঁ বলো না। হ্যাঁ জুলি ম্যাডাম আগে হবে, তারপরে যেরকম আছে সেরকম হবে।
I have sent.
হ্যাঁ
Hello.
Thank you, sir.
Yes, I have sent. Can you check?
Yes, I'm checking now.
আচ্ছা বলছি শেয়ার করা যাচ্ছে না, মানে শেয়ার হয়েছে তারপর পেজ ফরওয়ার্ড হচ্ছে না। কিভাবে
Download.
আচ্ছা এবার আমি যে এইটা আমার ডেস্কটপেও আছে, পেন ড্রাইভেও আছে, আমি ওটা নিতে পারছি না।
এটা করবো?
মেল থেকে খুলেছে।
ডাউনলোড হচ্ছে। ডাউনলোড হয়েছে তো? হ্যাঁ, ওকে।
So the school anyway.
বাবা কতগুলো দিয়েছে।
School lagada. Stop presentation ko. আরেকবার জানছি।
উইন্ডো করবো তো? এন্টার স্ক্রিন উইন্ডো করলে না এখানে ইয়ে চলে এসেছে, জিমেলের পার্টটা চলে আসছে।
এটা কেন চলে আসছে?
ওটাই তাই বুঝতে পারছি, আমার ইয়েটা আসছে না।
Microsoft
ইয়ে চলে আসবে। Have you seen the presentation?
তুমি বলো ওয়েট স্যার প্লিজ ওয়েট অ্যারেঞ্জ করো।
Same problem is here, sir.
Same problem is here, na?
Yes.
So why is the problem? I don't can.
Sir, try sharing the whole screen instead of the window.
Yes. Full screen. Okay.
কিছুই হচ্ছে না।
Entire screen.
Yeah, entire screen will work probably.
Okay. Yeah, this is the entire screen.
Yeah. Now, if you can switch to the PowerPoint.
Now in the entire screen, it is saying picture in picture open because your screen
You need
share.
to open your
We can see
PowerPoint
your screen,
presentation, sir. You need to open your PowerPoint presentation and just open it, then we will be able to see it.
Separate way. Okay. Separately.
Yeah.
You just go
Okay.
to the PowerPoint
Yeah.
file.
Now you
Let
can
it
open your PowerPoint slide, we will be able to see it.
Okay. Can you see now?
Yes, sir.
Okay.
Now you can go to the full screen.
Yeah.
Yeah. Now it is perfect.
That is perfect, na?
Yes,
Yeah.
sir.
Yes, yes.
Yes, now it's okay.
Now it is okay?
Yes.
Okay.
Yes, sir. Yes, sir. It's okay.
Okay. Okay. So we are stuck in the second slide, actually. So, what is the importance in modern healthcare system in this biomedical engineering? It enables the development of life-saving medical devices. Like we are seeing these pacemaker devices, which are life-saving. So there are lots of change in the pacemaker devices from single chamber to dual chamber. Previously, it is the pacemaker devices it is not MRI compatible. But with the help of this continuous research work, this pacemaker has become this MRI compatible. So if you want to do an MRI with the pacemaker in your heart, so you can do in nowadays, but it is not possible before. It improves the diagnostic accuracy and treatment precision, because some sorts of diagnostic accuracy, like endoscopy, like it was a very difficult to do the endoscopy procedure. Okay, the patient may have different problem, but with the help of different small cameras, nano cameras, even the robots has been used nowadays. It is a small capsule like thing. You have to swallow the capsule of the robot, and the entire the GI system can be scanned, and you can see in your drawing room the what is going on inside your GI system or GI tract, or your doctor also can see without any invasive procedure. It facilitates the personalized medicine approaches, contributes to the cost effective healthcare solution, supports remote monitoring and telemedicine. Advances in biomedical engineering lead to the better patient outcome. So our intention is to revolutionize to continuous upgradation, so that the patients the disease can be uh, can be diagnosed in a better way, and the treatment can be very fast, and treatment can be very successful. So all these are lead to the better patient outcome. It plays a critical role in addressing global health challenges, like the COVID. In the COVID scenario, we have seen that this is a global health challenge, but we have dealt with the help of this vaccine, the newer vaccines, and these vaccines are developed in a very short period of time. So this is a very fruitfulness of this biomedical engineering. Okay. The role of biomedical engineers in developing medical technologies. The key contributions of biomedical engineers are they design and develop medical devices and equipments. There are different equipments, maybe the monitoring system for the patient during surgery, and the monitoring patient during the intensive care, the ventilators, like different drugs, and the system, like we have seen in the modern operating theater, there is laminar airflow, and there is a temperature regulating system. So this has been incorporated in the modern operation theater to reduce the risk of infection. So we all know that there is an increased risk of infection in case of joint replacement surgery and some neurosurgery. But with the help of this technology, we can deal with this sort of problem. It improves the diagnostic and therapeutic tool, innovate in implantable devices and prosthetics. You have heard that previously, suppose if the patient having hip problem, hip fracture, that and the elderly patient, hip replacement is mandatory. But previously the implant is a sort of primitive implant, like Austin Moore prosthesis, Thompson prosthesis, and nowadays with the help of this system, this previous prosthesis is no longer used nowadays. We have done the total hip replacement, and in the total hip replacement there are different bearing surfaces, like metal and metal bearing surfaces. this gives a good longevity to the implant. So previously we used to hear that if we put an implant, its longevity is hardly 10 years or 12 years. But with the help of these researches, this processes, the lifetime of the process has increased much fold. It ensured the safety and efficacy of medical technologies, collaborates with healthcare professionals. This is a very important. The collaboration. Suppose a doctor in the India, if you want to consult, there's a difficult case. Want to consult with a scientist or doctor in the USA or the UK. So it is a helps in collaborate, or there is a in interdepartmental collaboration is also possible. Conduct research to advance the medical sciences, implement new technologies in clinical settings. So these are the vital roles of the engineers. Now these innovative approaches of biomedical engineering for the patient. So what are the different innovative approaches? So emerging technology in biomedical engineering and patient engagement, the key innovations are the emerging technologies are transforming patient engagement. It focuses on personalized care, remote monitoring, and interactive health management. The wearable devices are there. These devices are very early to detect any health condition, any critical health problem. Mobile health applications and telemedicine platforms are central. Now, what are the impact on patient involvement and health behaviors? Patient can track their healthcare data actively. Suppose if a patient with a chronic disease, with a carcinoma or the cancer, he has a long history. Suppose he has diagnosed with the carcinoma 8 years or 10 years before, and he has undergone some specific treatment like some surgeries, then chemotherapies, radiotherapies. Then after that, the follow-up becomes very easy, and for the patient it is, and for the doctors also, it is very easy for them to track their healthcare data, because there are different software system. So this software system, they can store, and they can actively produce this data whenever these are required and necessary. The enhanced communication with the healthcare providers. The different healthcare providers starts from primary healthcare center to the tertiary care center, from nurses to basic health workers to the physicians to the residential medical officer to consultants. So all level communication becomes very easy with the help of this application, different apps, and uh, with this system. So participation in patient plans is increased. So this is, so the patient, the treatment plan. So there will be different treatment plan for the same disease. Okay, it suppose it may be osteoarthritis of the knee joint, which is very common. So there are different treatment plans is available. So if the patient is 60 years, so this patient data can be percolated among the colleagues or senior juniors, everybody, so that they can give a good data on that, and this is a consensus of the treatment. Proper consensus can be getting. So the treatment may be initially may be conservative, then in the early stage, then the advanced stage, there may be the requirement some injections for the osteoarthritis of the knee. But when the knee is totally damaged, totally patient is, the knee is deformed and patient is not able to walk and maintain daily activities, then surgical intervention is required. So this planning is important, and the sharing of this plan to the patient is also important. So every time it's not need of the patient and patient family to go to the hospital or doctor every time. So he can communicate with the doctor online and get the treatment plan. It fosters the greater patient involvement and adherence to the treatment. So that treatment adherence is also very important. So patient compliance, if the treatment plan or the system should be hassle free as much as possible in now in these days. In nowadays, this should be hassle free for all the relatives of the patient, because all are busy. So it is not always possible to bring the patient to the hospital. It takes long time, whole the day in the hospital, and go home in the evening. And all the work are dismissed. So it is not possible. So it helps in a good patient involvement and adherence to the treatment. It supports the proactive health behaviors. You all know that in Bengal, in previous few years before, the treatment was not the communication system. This type of communication system was not that great, so that the patient can opt for the treatment in South India, in Vellore, Bangalore, in elsewhere. But with the help of these new technologies, patient involvement and adherence to the treatment has increased so much, so that the patient is no longer go to the South India or any other place of the India to get a proper treatment, because the treatment is almost the same. The main thing is that the patient adherence and the patient proper communication. It supports the proactive health behavior also. So these are the advancement in the wearable health technology. We all have seen there is a health technology like the smart watches, the fitness trackers, the biosensors, smart clothings are also there. So what are the uses of the smart watches? They can see the pulses, they can see the sometimes the blood pressure, the saturation. So if there is any problem, suppose there is some sort of arrhythmia during the activities like during jogging or during treadmill, so they can pick it up early. And if it is pick it up early, so the treatment can be given very early, and the patient's casualty or patient's morbidity and mortality is reduced. And these devices monitor the vital signs such as the heart rate, sleep patterns, the physical activity. So how much steps you are doing per day, and how much calorie you are burning. This is very much important to get the patient fit, because sometimes we all know the obesity is a cause of all the diseases. Most of the diseases like hypertension, like hypercholesterolemia, heart disease, like cardiac problems, orthopedic problems also, knee problems, hip problems, spine problems also. So all these diseases are due to the obesity. So if the obesity can be controlled, then this further morbidity and mortality of the patient can be reduced, and this can be done with the help of these devices, the smartwatch. And these are produced by the engineers, the biomedical engineers. So they are the vital role. So sometimes they can detect the blood oxygen or glucose level also. So if the patient is a diabetic patient, he has to take the insulin, he has to take the oral hypoglycemics, and this can detect whenever there is a hypoglycemia, because hypoglycemic attack is one of the serious concern. And if it is not detected at the early stage, then we can lose the patient or the person. So hypoglycemia, they can detect the hypoglycemia, and hyperglycemia, if the sugar is increased, then it can detect also. So there's an integration with these watches with the smartphone and cloud platforms. It allows the real-time data tracking and personalized health insights. So they can put inside what should be done, what not should be done. If you said that, yes, I have to walk per day around 10,000 steps. So if you someday if you have walked 7,000 steps, they can remind you that, yes sir, you have not walked 10,000 previous day, so you should do today. So this is the thing is very important nowadays, and it makes the person more fit and healthy, because we all know that the prevention is more important than the treatment. If we can prevent the disease at the early phase, then we can treat that that phase, and the results are very, very good. The recent innovation and impact in the health devices, the recent advances features continuous monitoring, the improved accuracy, and AI-driven analysis. Suppose if a patient in the ventilator, so it is very difficult to sit by the ventilator and see what the readings, what the pulse, BP, respiration, temperature, saturation, everything. So there are different sound system with different sounds. If the BP is low, they can put a different sound. If the saturation is low, they can remind the physician the saturation is low. You can come and do whatever you need. So these things has good in the patient management. Devices now detect the irregular heart rhythm, the stress level, early signs of illness, and this wearable support remote patient monitoring, the chronic disease management. Like I have told, like disease like cancer disease, chronic kidney disease, because the patient may take the dialysis. In chronic kidney disease, the patient may require dialysis thrice a week, and in that case this recent innovation, this technology can make the patient aware the what is the health problem, and the proactive healthcare system is also necessary to get a good patient and patient doctor relationship. The empowering users and healthcare providers with the actionable data. The telemedicine in patient monitoring, enhancing care through remote technologies. So what are the benefits of telemedicine? It enables the remote patient assessment and management. It reduces need for inpatient visit. So this is very important. So this reduces the resources. So a doctor can see a patient in his drawing room in around 9 o'clock, 10 o'clock even. He can he can see the emergency of the patient without going to his home. So home visit, it was what was much more in the previous days, is reduced now with the help of these technologies. So in the drawing room, the surgeon or the physician can see the patient, can see whatever things are required. He can measure the pulse, can measure the temperature, okay, and he can give the treatment, emergency treatment for that purpose. And if hospitalization is necessary, he can tell this condition is serious, you better to go to the hospital emergency and admit the patient. He needs some he need admission. So there is a big huge changes. It improves the access to healthcare in remote areas. We all know, because in Kolkata, there are in West Bengal, there are certain cities, the healthcare system is good there. But even you can see the remote spaces like villages, the healthcare system is today is very much poor, because the lack of manpower is more important, and lack of infrastructure also. So with the help of these gadgets, there is some sort of this gap can be reduced. So the patient, any sort of the maternal mortality. The maternal mortality is a very important source of mortality in India today. So we can reduce the maternal mortality with this early detection of the signs, early detections of the blood pressure, the temperature, pulse. These are the vital signs, and early detection of this abnormal of this vital sign can save a patient for a permanent damage. Allows continuous monitoring of the vital signs, facilitates early detection of the health issues, enhances patient engagement, and supports the efficient use of the healthcare resources. The healthcare resources are, it is very important to get a proper use, efficient use of the healthcare, because in India it is the healthcare system is there, but in the remote places the healthcare resources are not used at a proper way. But with the help of this biomedical engineering, telemedicine and everything, so we can get a better healthcare resources, because doctors are there. So if a doctor has to come to his home to the hospital, it takes 3 hours, 3 hours to go to the hospital and 3 hours back to his home. So this time he can use with this application, with this system, you can save thousands of patients from a serious illness. So technologies used in telemedicine, these wearable health devices, sensors, remote patient monitoring platforms, video conferencing tools, that's very important, mobile health application, and the storage of the data in cloud, and definitely the artificial intelligence for data interpretation. So the key benefits and challenges of telemedicine in patient monitoring. So what are the benefits? The early detection. The early detection and prevention. These are more. We are behind the UK and US and other countries, because the detection, we detect the disease at the late stage, and there is a very less preventive measures. So if we focus our government focuses on the early detection and prevention of the diseases with these technologies, then the healthcare is will not be overburdened, because we get the patient at the most of the case in the late stage, when the prevention is not possible, and the go to the previous disease free stage is also not possible. So this should there should be emphasis on the early detection of the disease and prevention. The preventive health has is a very important role in the preventive health, preventive medicine. The personalized care plans, it increases the patient engagement, as I told, makes the healthcare more proactive and improves the healthcare efficiency, and enhancing the patient-centric care. So the care we are giving should be patient-centric, what the patient required. It is not that the patient is not required. So always should be what patient required, what the patient need. That is more important. And if it due to the time and due to the availability, if the patient coordinates to the healthcare system is reduced, then there is a more chances of disease recurrence, and it is not possible to stop the disease at the early phase. And if we get a patient in the later phase of the disease, then the healthcare burden is increases, the cost, the healthcare cost of the patient and the government is increases for the government hospital also. So this is a paramount important in, and this can be dealt with the help of this modern medicines, modern biomedical engineering and technology, artificial intelligence and robotics. Now challenges, say it is not without challenge. So what are the challenges? So data privacy. So there should be the data privacy, because we can't share a data, patient's data, one patient's data to the another without his consent, and the patient's data with the another doctor. So this patient's disease should be the prioritized, and the privacy is maintained, because if the privacy is not maintained, then it is not a proper healthcare system. So this data and the storage system, everything should be very private, and it should be specifically pinned, and it is good with the help of AI. The integrated technology with the existing system, it addresses disparities in digital access also. Now comes the robotics. The integrating robotics in surgical procedure. So previously we used to see, like, that difficult surgeries. You can start from the GI surgeries also. So GI surgeries, like the most of the previous GI surgeries or cancer surgeries, are open surgeries. Open means you have to give the incision to the patient if it is in the intra-abdominal, if you give the incision to the abdomen, and you have to access the area, and it leads to the lots of problem, like it leads to the blood loss, it leads to the infection, it leads to the more hospital stay, patient morbidity is increased, and the time also is increased. So the patient may get so the patient's relief from the disease free time is also is much increased. So these are the very hurdles, but with the help of this robotics, the surgery can be done at the very fast and very flawlessly. So what is biomedical robotics? It is a research. The focus area is centered on the design, development, and evaluation of patient robotic system and smart assistive robotic platforms that enhance the physical capabilities of both patients and clinicians via advancement in and medical design, modeling, and control sensor. So these are the biomedical robotics. So always the robotics are here to hold the hand. It is always there to help the patient, help the surgeon. So it's a newer technology. So we all should accept that science. This is science, and science is always the evolving science. It is not constant, because we have heard in the previous. So it is there is a, as the researches are going on, there is a lots of change, and if we not cope up with this change, then the patient's management, patient's treatment is not that good. So with the help of this technology, because previously we have seen in diabetes there are very 3-4 medicines are there, but with the help of newer molecules, newer biomedical research, the newer molecules are coming, which gives a very good effect, very good result of treating this diabetes mellitus. So robotics is an interdisciplinary research area at the interface of computer science and engineering. The robotics involve the design, construction, operation, and use of robots. The goal of robotics is to design intelligent machines that can help and assist the humans to day-to-day activities, day-to-day lives, and keep everyone safe. So robotics is not that the robot do the everything. It can replace the humans. It's not that. In medical science, most of the cases, the robots is guided by the human or the surgeons or the physicians. It is not always the autonomous robot. So you can change if there is any problem in the robot. So you can say it is a much educated, much experienced assistants in a surgical field. So this is a robotic system. This is used in GI surgery or cancer surgery or neurosurgeries also. This is called the Da Vinci system robot. It is not the orthopedic robot. So these can do the endoscopic surgery. It is not doing the open surgery, the endoscopic surgery. There are 3 arms of the robot. This is the robot. You can see this right is the Da Vinci system. So this is the robot, and there are 3 arms, 1 and 2 and 3. So with the 3 arms, there are 3 limbs, and there are 3 ports in the abdomen, like laparoscopic surgery. You have seen the laparoscopic surgery. There are 3 ports of the laparoscopic surgery, and with the help of this robotics, this robotic arm goes inside the patient's abdomen, and they can dissect the actual area of the disease. So all the areas of dissection, at the open surgeries, the blood loss is very minimum, and the dissection is very perfect. And you all know there's a human, the surgeon is a human, so there may be some human error also, and the limitations also, like the surgeon he has to do the surgery with the help of the hand and the wrist, so the wrist movements are there. So the wrist movements are maybe dorsiflexion, volar flexion, ulnar deviation, radial deviation. But with the help of this robotics, this robotic arm can move in a 360 degree. It is unlike the arm of a surgeon. It is an example. Suppose if you want to stitch the roof of the abdomen from inside, it is not possible to do a laparoscopic surgeon, but the robot can stitch the roof, okay, with the help of this robotic arm, dexterity and flexibility. The person here is a assistant. His function is to put these robots inside during surgery, and the surgeon is there in the console to operate all these things. He can control all these things. Next. Okay. So the most medical robots are indeed designed to cooperate with the surgeon and assist them during the operation. Among these, the robotic handheld surgical instruments are enhanced the mechanotropic tools with a certain degree of intelligence and autonomy. They can assist the surgeon by adjusting the movements and constant the level of interaction with the operative fields. During the last 3 decades, the medical robots has been increasingly used to perform many health tasks and very difficult health tasks. As such, they show promising future potential for the use in a wide range of healthcare issues. So we can see there is a system that the robot can do. Robot can any intra-abdominal diseases, whatever may be, it can be done with the help of the robot. In the past few decades, surgical practice has been revolutionized by introducing advanced instrumentation, enabling a paradigm shift from traditional open surgery to minimally invasive surgery. The main advantage of MIS is attributed to a reduction of the patient trauma, lower hospitalization cost, reduced tissue scar, surgical trauma, less pain, and more important, there is a faster recovery. So the nature of MIS or laparoscopy, for example, which involves use of long rigid tools inserted into the patients via small incisions, it can do a range of ergonomic challenges. The loss of wrist articulation and the fulcrum effect caused by the inversion of the motion detection at the trocar limits the surgeon manual dexterity. The use of separate display conveys the visual feedback from a laparoscopic camera separates the visuomotor axis, thus affecting the hand-eye coordination of the surgeon. The improved control and dexterity are the main benefit of robotic technology for MIS, like minimally invasive surgery. The mechanotronics enhanced the surgical instrument has been designed to compensate for the loss of wrist articulation caused by the traditional approach. The medical robots are robotic machine utilized in the healthcare machine. So there are 3 main types. The medical devices include the surgical robotic devices, the diagnostic purposes and drug delivery devices. The assistive robots include the wearable robots and rehabilitation devices. The robots mimics the human body, including the prosthetics, artificial organ, like for amputee, whenever the limb has been lost by some accident or any disease, and the body part simulators. So these are the types of robot in the healthcare. There's a prosthesis and artificial organ, body part simulators. These are the humanoid robots. The medical robots are the surgical robots used for the diagnosis and intervention. They like drug delivery robots, and the assistive robots like wearable robots, which I have discussed, and the rehab robots or rehab devices. Now there are lots of companies in the globe which has come with a different robotic system. So this is not confined to a general surgery or particular stream. These are in all sorts of surgery. In the orthopedics, we are using the robots mainly for the joint replacement, and there's an arthroscopic robot has come very recently in India, and the spine robot is also there. They can do the spine surgery with the help of this robotic system. The common robots are the Johnson and Johnson, Smith Nephew, Medtronics. We have heard the name, the Striker. These are the very big name. The Jimar Biomet. These are the big name, Olympus. So these are the big names in the field of robots. So what are the major drivers in medical robots market? There is an advancement in healthcare spending and infrastructure, the research and development activity by medical technology, healthcare companies, the rising prevalence of chronic disease in the elderly population. So as there is a rising prevalence of the chronic disease and there is a research and development, so there is a growing prevalence for minimally invasive procedure. For the elderly population, these are very high risk zones. The patient may have some cardiac problem like diabetes, say COPD, like all other health issues. So the open surgeries becomes very risky for them. So with the help of these robots, the minimally invasive technique, the patient risk of the surgery is reduced, and the patient's outcome is much improved. But there are barriers. It is not without barriers. So this is the machine. So there may be some malfunction of the robot system. The acceptance and resistance by the user and healthcare professional. So if a robot come to our healthcare field, you should know and should have the training to operate the robot, and not only the surgeon or the physician, all the person who are involved in the healthcare system, starting from the paramedical staff, the nurses, everyone should know or should learn how to use this robotic system. And there is a lack of skilled professionals are there. So this training is important in that case. The cost is very high. So that's why it is not popularized in our day-to-day practice, because our patient is, because if it is a high cost, is whatever maybe from government perspective or the private perspective. So this cost, there has to be some, it has to be taken care of some part by the care takers, like the patient and relatives. But due to the high cost, we are not able to give always these services to the all of our patients. Now, state-of-art robotics in the field of healthcare. The surgical robots are robotic surgical system used in minimally invasive surgery, controlled by the surgeon to perform precise movement with robotic arms and infrastructure like Da Vinci system I have discussed. The telepresence robot, this is a more important, the telepresence, they enable the remote surgery. Suppose the surgeon is in the China and he does surgery in the Vietnam. So this requires this telemedicine surgery. The surgery can also be done, allowing the surgeon to control a robot from a different location is potentially providing the expertise to the area lacking the specialized medical profession. So it reduces the time for the surgeon or caregiver to go to the place, do the surgery and come. So this time has been reduced. So, and it is also cost effective for the patient and healthcare system also. Rehabilitation robots, exoskeletons like wearable robotic devices assist patients with limb weakness or paralysis in regaining mobility and strength through controlled movements. Gait training robots aid the individual in recovering walking abilities after injuries by surgery by providing controlled support and guidance. So these are the rehabilitative robots. Diagnostic robots are there. They assist imaging, the robotic assisted imaging. They assist in precise positioning for the medical imaging procedure and ensures the accurate and consistent result. Lab automation robots, it assists in laboratory tasks such as example is a handling, testing, analysis, improving the efficacy, efficiency and reducing the human error. The telepresence robot I have already discussed. It has a remote presence system, allow healthcare professional to remotely interact with the patient and providing the consultation, monitoring and support through robotic interface. Pharmacy automation robots are there. They automate the process of dispensing and managing. These are the right hand side. You can see the pharmacy. So the robot has been installed in the pharmacy. They can hear what is the requirement from the patient and they can pick the medicine, proper medicine, and can deliver the medicine to the patient and get a proper bill also. So processing in dispensing and managing the medication reduces the error and improve efficiency in the hospital pharmacies. Robotic prosthetics, bionic prosthetics, advanced robotic prosthetics that use sensor and microprocessor to mimic natural movement, providing the greater functionality and control of the amputee. The robotic assisted therapy, the therapy is also available, like some of the therapeutic interventions for the patient with various conditions like autism, which is increasing manifold nowadays, dementia, as the patient are gaining the older, the chances of dementia is increased, and the patient's life expectancy has increased nowadays. So the dementia can be dealt with the help of the socially assistive robot by providing the compassionship and the assistance. The endoscopic robots are there. They assist in endoscopic surgery by providing enhanced dexterity and precision. I have told the nano robots. These are the emerging, the nano robots. But these are not this is mainly the theoretical. An emerging field, it involves an extremely small robot which can operate in the cellular or molecular level for the diagnostic or therapeutic purpose. Suppose the patient is a cancer patient, so it can go to the cancer cells and it can damage or it can destroy the cancer cells at the very small amount of area. So this leads to the adverse effect of chemotherapy and radiotherapy, because in chemotherapy, radiotherapy, we all know there is damage of the normal cells also. Now, the cyber knife and gamma knife system that uses the robotic arm to deliver the highly focused radiation to tumors with sub-millimeter accuracy and minimizing the damage to the surrounding healthy tissue. This is the CR machine. This is a very common machine used by the orthopedic surgeon nowadays. This is a medical robotic navigations referred to the advanced navigation system with the robotic technologies to enhance the precision, accuracy, and efficiency in various medical procedures. The navigation system provides the real-time guidance and visualization to the surgeon, allowing them to perform a complex task confidently. So this is the navigations, robots for navigation. A robot arm moves in the surgical instrument. This allows the precise positioning based on the preoperative planning and imaging. The motion of the anatomic structures caused by the respiration and pulsation can be tracked. Robots for motion replication. The robots replicate the surgeon's hand motion via the passive robotic interface. Thus, we can downscale the motion, reduce the shock, and improve the minimally invasive methods. Robots for imaging. An imaging device is mounted to robotic arm for the 2D and 3D images. Rehab and prosthetics. The mechanotropic devices can support the recovery process of the stroke patients. Robotic exoskeleton controlled by the brain-computer interface can replace or support the damaged anatomical structures. Now, some key aspects of medical robotic navigation. So surgical navigation system, the image guided surgery utilizes the preoperative or intraoperative imaging data such as CT scan or MRI, which has to be fed into the robots to create a 3D map of the patient's own anatomy. This map is then used for the real-time navigation during the surgery. In most of the cases, the knee replacement, we have to take a CT scan of the knee, and this CT scan has to be given to the robot so that so that he can know that this is the anatomy of the patient. This has to be done for the patient. Robotic surgical navigation. So robotic assisted navigation integrates the robotic system with the navigation technologies to enhance the precision and compatibilities compatibilities of the surgical robots. The surgeons can benefit from improved visualization and guidance during the procedures. The orthopedic navigations, like computer assisted orthopedic surgery. It uses the orthopedic procedures. This navigation system aids in precise implant placement, alignment, bone dissection, improving the overall accuracy of the surgeons, such as the joint replacement. Neurosurgical techniques, the intraoperative neuroimaging enables the neurosurgeon to navigate and visualize the critical structure in the brain during the surgery and enhances the accuracy of tumor resection and other neurosurgical procedures. Now, there are three types of robot in orthopedic field. There's a haptic robots, autonomous robot, and the passive robots. The haptic means that they allow the surgeon to use or drive the robot to perform the operation. It requires a constant input from the surgeon. So it is a good assistant of the surgeon. So surgical precision can be better with the use of these haptic systems. Autonomous system, it requires surgeon to perform the approach and set up the machine, and this surgery can be done with the help of the robots. And these robots, one engaged, the robot completes the surgery without the surgeon's help. So that's why it is autonomous. It is autonomous. It can done the surgery with its aim. The area of interest in the robots. So we have done all the procedures with the help of robots. Like in the knee, we can do that unicompartmental knee replacement like UKR, total knee replacement. So UKR is more common nowadays because in the knee arthritis, only the 1% of the knee is damaged first, like the medial compartment. So if the compartment can be replaced with the help of this UKR or UKA, this knee, the tendency to go to the total knee replacement has reduced, and this UKR is a less invasive than the TKR, and the longevity of the UKR is much more than the TKR. In the hip, we can do the total hip replacement. The foot ankle surgeries like roboted guided intra-articular injection to the different joints of the foot and ankle, and the shoulder surgery, the shoulder arthroscopy, the spine surgery for the placement of the pedicle screw in the spine surgery, or there are injections. Trauma and general orthopedics also. The navigation of the entry point and distal locking bolts of the intermedullary nailing. In intermedullary nailing, the distal locking screw insertion is the most difficult part, but with the help of the robot, this can be done with ease. The aiding the reduction of the femoral and tibial fracture also. Identification, dissection, and primary repair of the nerves in brachial plexus injury or brachial plexus surgery. In research part, that teleoperative robotic assisted or autonomous robot performs the surgical stabilization of the critically wounded patients, particularly within the military sphere, but there is a very difficult to go to the doctor or ambulance or any hospital to go to that area. So this telemedicine or these telerobots can do the job. With the trauma pod or the semi-automatic telerobotic system. But it is not all about, it has some advantages also. It is the ability to perform the minimally invasive surgery, is improved accuracy of the implant placement in joint replacement surgery, is improved radiological alignment of the extremities, and definitely there is shorter hospital stay, less blood loss, and greater accuracy. But what are the pitfalls? Again, it is expensive. It is not. It is like this type of issue is not always possible to give to the everyone. So it is a constant software upgradation and calibration will add to the cost. Long-term outcome studies are necessary to demonstrate the superiority and cost effectiveness of robotic surgery in routine practice. So it is not foolproof. The robotic is better or best. So it times which tells the whether the robotic surgery is good or better than the conventional surgeries. So it is unable to manage the soft tissue dissection by itself for the orthopedic practice. Orthopedic robots just do the bone cuts, bone preparation. They can't do the soft tissue. Previously, the total knee replacement are used to say like soft tissue surgery, like balancing. We have to balance the knee in the full extension, full flexion, mid flexion, everywhere, varus, valgus. But the robot can do the soft tissue balancing. Where the surgeon should do the initial incision, if you dissect the soft tissue, then robotic arms are going inside the knee, they do the femoral cut, tibial cut, and there are different sizing jigs are there to complete the surgery. The robot talk fell into the dispute because it has associated with increased risk of infection, blood loss, neurological damage, and increased rate of litigation. The litigation also is increased because because there's a very difficult for the robot to recognize what is the artery, what is the nerve, and what is the soft tissue, what is the difference unless and until surgeon's guide. So not all robots are good. Some robots are good or very good with surgeon's own hand. So surgeon always required to operate the robot. Now this is a robot. This is an orthopedic robot. You can see there is a particular robot for the knee replacement or unicompartmental knee replacement. Like this is called the Rosa. The name is Rosa. It is a Jimmer, the Jimmer Biomet robot. It's for knee replacement. So it commit to the highest standards of patient safety, quality, and integrity. And there is a winning combination of the robot with the optical navigation, 3D planning, and the Navy tracker. And there is always the robotic expertise or imaging solution expertise in TKR and data exchange portal. So with the robot, we can use all sorts of implants. There are different types of implants we can use according to the patient needs. So surgeon can ultimately tell which implant is necessary for the particular patient, and he can install that particular. Like if you want to install a Vanguard, then the Vanguard system, the Vanguard application has to be on in the robot to perform the surgery. Or the next gen or the personal, these are different, but the basic things are the same. So this is surgeon centric. This is more important. This is surgeon centric. It is not without the surgeon. Always the surgeon is required in each and every step to do the surgery. Bone, cartilage, soft tissue values are there. You can see, and the real-time intraoperative feedback and decision making is important. The validation of the cuts. If the cut is there, you can validate the cut, and it is a good platform to do the surgery. So there is a flexibility in the operating room setup. You can these are the screens of the robot. This can detect at any point of time what you should do, and the surgeon should do all the procedures to start up the robotic system. So this is the small. You can see the setup. This is a patient is lying. The robot comes from this side for the knee replacement. Suppose this right knee has to be operated. Then this is a Rosa. This is a robot. Some technician has to bring the robot to the particular position where he can do the surgery or he can assist the surgery. And this is the help of some infrared rays. So the tracking is very important. The infrared tracking. So in the camera position, this is a surgeon setup. If you want to do the femur tibia evaluation planning, and this is a patient's own details. Okay, so suppose in the femur size there are different sizes from 7, 8, 9, 10 bearing surface tibia size. So this is the patient is lying down. This is a robot surgeon is in the right hand side, and this is the green is the optimal position. You can see whenever there is a green. If there is a green, then these trackers can get the good infrared signals from the robot and the system. So this is for the femur preparation, the landmark acquisition and display recommended location in the 3 colors. There's a white, yellow, and green color. So the 3 different colors in different parts. Like in the femur, we have to tell the robot this is a medial femoral condyle. So medial femoral condyle, there is a 3 points. Lateral femoral condyles, there is a 3 points. In the trochlear notch, there are 3 points. The PCL, this is a PCL insertion site. The PCL insertion site or the trochlear notch, there is a 1 point. Okay, so this is how you should know the robot. This is your anatomy, and this is with the help of these instruments, this landmark acquisition instrument. So after that, robot can tell how much resection it has to be done from the medial side, lateral side. Okay, and you can this is a planning. This planning you can tell, because in the conventional surgery we just do the cut, and the planning we can do the planning outside the operation theater in templating. So this templating is better, is judged or can tell by this use of these robots. So it can tell you everything. It can tell you the planning, how much resection, how much soft tissue, how much bone, from where. Okay, and this gives a good precision. So this is a planning. You can see the femur, how much femur has to be cut, how much tibia has to be cut. Okay, so these all are helps in planning, and you can undo also. If the robot is not doing or not telling good, you can undo or you can change it by its own. Suppose in the most of the robots, I have my experience to see the tibia has cut is much more. They tend to increase the tibia cut more, so the poly inserts become larger. So in that case, we can reduce the amount of tibia cut so that the balancing should be appropriate. Now, this is a navigation and computer assisted in the arthroscopic surgery. This goes to the joint replacement. Now the arthroscopic, like ligament reconstruction, like ACL tear. We have heard the ACL, the knee joint, the ACL tear is very common. PCL tear is very common. The meniscus tear, cartilage tear is very common in the sports individual. We used to do by the arthroscopy, with the help of arthroscopy. Previously, it is done with the open surgery. Now we can use the arthroscopy. There is an advancement from arthroscopy to the navigation assisted arthroscopy. So computer assisted navigation system with the arthroscopy. So the error become very, very less. The proper tunnel position for the ligament reconstruction, and it gives a good real time guidance for the surgeon. And this extended reality, this is a virtual reality or augmented reality, and this is very important in surgery, in planning. This is interpretive guidance also, and it is very important for the training of a newer surgeon, because he is not able to do a living patient. He can do in his home also, or in the hospital. You can train. The coordination is important. For surgery, the coordination. A young surgeon is very difficult to go to the patient and do the coordination. So he can do the coordination with the help of the virtual reality. The robotics in the operating room in arthroscopy, the robotic assisted arthroscopy has enhanced precision, reduced human error, and potential for shorter surgery duration, in primary for the hip and knee ligament surgery and cartilage repair. Now, there are advantages over the conventional surgery, like knee arthroscopy is technically demanding procedure. The current arthroscope do not provide the depth of vision. It is a rigid, cannot negotiate the deep curves in the knee joint. It's a very limited field of vision in conventional spaces. So if there is a human error, then the result is suboptimal. Always remember, all these are used to good optimal result, because the surgeons also are humans. So there may be some errors. So these errors can ultimately lead to the suboptimal result to the patient. So advances in robotics can help in the future. There are 4 areas of development in the arthroscopy of the robotics: steerable robotic tools, leg manipulator, miniature stereo cameras, 3D and 4D imaging system. Now, robotic system in the surgery, we have all discussed about the advantages, pitfalls, or I have discussed. These are the enhancing patient proficiency. The digital transformation in healthcare system, the technology is transforming how the patient and healthcare professionals interact. The digital tools enable the real-time communication and easier appointment scheduling. The patient portals provide the access to the medical records, and innovations help bridge gaps caused by the distance, time constraint, and the language barriers. So what are the benefits from the patient and from the surgeons? So patient benefit, patient can ask questions. It is not that the previous way you used to see the doctor has written, yeah, this has to be done. Okay, sir. So patient is not able to do the question. Now the patient has knowledge. So it is important. Patient can Google, because it is own body. He has to do some questions definitely. So patient clarity has been improved. They receive timely updates, better understanding, and patient understanding means a better outcome, because patient, this is a team. The doctor, the healthcare system, patient, relative, all these are in the team. So if somebody doesn't agree, then it is not success. Okay. This improves the patient engagement and satisfaction. So what are the benefit of the healthcare professional? It's a streamlined workflow. It reduces the error. It supports shared decision making and enhances the communication effectively. So AI for the personalized patient care and organ transplant also has come. So this is the organ transplant. The AI transform the personalized patient care by analyzing the large data sets to tailor the treatment. Machine learning identifies the patient-specific risk factor, predicts the disease progression, and recommends the individualized therapy. More accurate diagnosis results from AI, along with the optimized medication plans and improved patient outcomes. The real-time monitoring is enabled by AI, allowing for early intervention and continuous care adjustment. So this organ transplant, like head transplant, can be done with the robots and AI. Can you imagine? So AI enhances the donor recipient matching, because this is the most important cause of this failure of organ transplantation, this matching. So they evaluate by complex compatibility factor beyond the traditional criteria in organ transplantation. In predictive algorithm, assess the organ viability and forecast the transplant success. AI helps prioritize the recipient for organ transplantation. AI-driven tools streamline logistics and reduce the wait times. AI support post-transplant monitoring, ultimately increasing the survival rate and transplant efficiency. So what is the future of BME and healthcare? The healthcare connectivity is expanding through secure data sharing. Interoperability between the system enhances the collaboration. Remote care solution improves the access to the medical service. Connectivity supports the collaboration among the healthcare professionals. Streamlines patient care and increases access in the remote areas. Advances in the digital infrastructure drives integration of BME and healthcare. And what is the impact? It leads to the more efficient, patient-centric healthcare. It creates more accessible healthcare system, supports digital infrastructure development, facilitates the integration of biomedical engineering with the healthcare, enhances the remote healthcare delivery and the telemedicine, and it promotes the collaboration access to the healthcare providers. So the doctors are engineers. So why not both? So the biomedical engineering or the we as should knowledge in both. Not only that the doctor, the knowledge of the doctor or the knowledge of the this anatomy or physiology or medicine knowledge is not enough. The technology is evolving, and we should know the technology for giving the patient better patient outcome. This is all about this robotic joint replacement. So this is the trackers is used. These are the trackers, and there will be a monitor, and the robot comes. This is a robotic arm, and robot cuts the guide, and this is all about the robotics. Thank you so much.
Thank you very much, sir,
Okay.
for your inciting talk on the application of biomedical engineering and robotic technology in the modern medical science, especially in critical surgery. Okay, now we'll open the sessions for question answering. We request all the participants first state their name and the name of their institution before asking the question. Firstly, we have got a question through chat box. Ma'am Navanita Ghosh, her mic not working, so I just read the questions.
Okay.
Sir, what are the current advancement in surgery of the vertebral column? Spinal surgery had been especially difficult, and patients who did surgical intervention are scared to God for it. What is the success rate of such critical surgical surgeries based on the current techniques?
Yeah. So I am not a spine surgeon. First to tell, I am basically a joint replacement arthroscopic surgeon. But yes, the spine surgery there is a revolutionized the spine surgery with the help of there is intraoperative CT scan machine. We have seen the CT scan machine. It is called O-arm, because in the spine surgery, what we can use with the help of the CT scan, with the help of C-arm, we can put the pedicle screws or the instruments with the help of this, with the use of C-arms or the instrumentation. But with the help of this OR machine, like the CT scan inside the OT, you can very thoroughly delineate the surgical fields, the bony anatomy. You can do the precise location of these pedicle screws or instrumentation, or it is much helpful whenever there is a multi-level correction is required. Suppose there is a multiple vertebral fracture, there is a kyphosis, or sometimes in the scoliosis also. In the scoliosis, there is a curvature. You have to correct the curvature. So for the curvature, with the help of the robotics, they can give the proper assessment, the interpretive assessment, how much correction has been done, how much correction is required, and secondly, the patient monitoring also. The neuro monitoring system for the scoliosis surgery has also become available nowadays with the help of the scoliosis surgery become. So for multi-level decompressive spine surgery, this AI and robotic has a very good role.
Okay, another question we received from Dr. Shyam Sarkar. How does a robotic system assist in accurate implant posturing during knee or hip replacement?
Yeah, I have probably already told. Say the proper placement depends on the patient anatomy and where the patient knee or hip is whenever you are operating. So this anatomy, it has to be given before preoperative by a CT scan, and intraoperative whenever you are moving the knee joint from the full extension, full 90-degree flexion, full flexion. the varus or valgus space. This can be given with the help of the tracker system. They can track, they can sense, and they can tell you in the screen. This is a balanced knee. So our purpose in the knee replacement system surgery is to do a balanced knee. Okay, so balance in both flexion and extension. It should not be too tight. It should not be too loose. If it is a too tight, patient may be in some pain post-operative. If it is a too loose, then it is unstable. It is a failure. So there's a perfect feeling of the two between too loose and too tight, and it helps in proper positioning of the implant, both the femoral and tibial.
Okay, thank you very much, sir. Our next speaker, Professor Amirul Islam Mollik, sir, already joined. So
Okay,
we
thank
need
you so
to
much.
stop this session here. Thank you
Yeah,
very much, sir. And I also thanks all the participants for their active engagement.
okay.
Thank you.
Thank you, thank you.
Now I would like to warmly invite our second speaker, Professor Amirul Islam Mollik, sir. Please take the stage.
Yeah,
Thank you, sir, for joining.
thank you.
Sir, I am Dr. Aftab Hussain Mondor, working as Assistant Professor Microbiology Departments. It is my pleasure to introduce you. Sir, Professor Amirul Islam Mollik, an eminent scientist and academician currently serving as a professor in the Department of Biological Science at the Indian Institution of Science, Education Research, Kolkata since 2014. He also carried out extensive postdoctoral research at Sunnybrook Research Institution, University of Toronto, Canada, and Ontario Veterinary College, Canada. He has received many prestigious awards and fellowships, including the Scientific High Level Visiting Fellowship 2024, ICMR DHR International Fellowship 2022, and Early Career Research Award from SARP India 2015. Sir has published more than 70 research articles in very highly reputed international journals. He had guided more than 10 PhD scholars and 2 postdoctoral fellows. Sir has extremely got funding from various agencies like DBT, MOE STARS, Indo-UK Joint Research Project. It is an honor to welcome Professor Amirul Islam Malik sir as today's speaker, and we look forward to his enlightening presentation on the topic extracellular vesicles, versatile nanocarriers for multimode therapeutic and diagnostic applications. Please, sir, start your presentation.
Thank you. Just a second. So please tell me if my entire screen is visible.
Yes, sir.
Yes, sir, visible.
Yeah.
Yes, sir, visible.
First of all, I sincerely thanks the organizer, especially UGC-Malaviya Teachers Training Program. I recently also delivered a lecture in Assam University, Silchar, and now organized by Maulana College, Kolkata. It's my privilege to be here as a speaker, and today I will be talking about the different aspect of extracellular vesicles, which will cover a wide range of biological vesicles released by gram-positive bacteria, gram-negative bacteria, as well as our own system like mammalian system, also that is called exosomes. So before going to that, it's as our mandate for ISA Kolkata, that's to spend 2 slides to reach out for our institute. I belong to Indian Institute of Science, Education and Research, which is located in Kolkata, and there are nearly 7 ISRs at different locations around the country. Among them, ISA Kolkata is the oldest IIS here in this system, and we have a vibrant community of nearly 2,000 students. We have an in-house system for students, residents, faculty residents, and many other activities which students prefer in a campus life. ISL Kolkata has 7 departments altogether, with 150 faculties, nearly 1,500 students, and also there are among them 500 are PhD students. Among the important departments are biological science and the chemical science. There are other departments which is also, some general streams department, like we have interest in the humanities and social science, and we have a newly formed department which is Department of Computational and Data Science. We cover BSMS or dual degree program. We also offer masters in science programs, then integrated PhD program, along with doctors and postdoctoral trainings. With related to my little bit background, I am a trained veterinarian. I received my veterinary degree from West Bengal University of Animal and Fishery Science. And then I did my PhD in Aligarh Muslim University. Following, I did postdoc in University of Guelph. It's one of the important veterinary college in the North America. Following, I did another postdoc in University of Toronto under Sunnybrook Health Science Centers, and 2014 onwards, I am associated with Indian Institute of Science, Education and Research. Here in the biological science department, my primary interest is understanding the molecular mechanism of host pathogen interaction, where, as you can understand, that it's a wide topics, and it's a lot of things are involved. So my specific focus is understanding this response in the mucosal surface. Mucosal means our oronasal, gastrointestinal, the largest, you can say, that organ system in our body. For this, the main thing that I want to focus here is whether any infection or any bacteria or viral pathogens, when enter inside the host, what is the outcome, whether it's an immunity or an infection. So I don't think in between there is any other state of residence. So for immunity and infection, the determining factors primarily, as you know, that the pathogen, how they transmit, and what are the level of host susceptibility, different environmental factors, virulency and toxic factors, or other way the pathogenicity markers, reporters genes, which are involved in direct or indirect pathogenesis of a particular bacteria or virus, and of course the route of entry, and over the time the microbial evolution are the key factors to leading whether the infection or immunity caused by a host or by a pathogen, who is going to be the winner basically. So this talk is also, I'll give 2 slides, brief overview of why I'm working in this area and how relevant to the topic today with the existing problem or issues that we all are trying to solve is One Health issues. So one of the important factors or the mission for One Health approach is prevent, protect, and coexist, which is not as easy as it seems to be, because coexistence creates a lot of problems, and this coexistence we have to achieve without any negative effect. However, the human-animal interface, particularly habitat encroachment, modern urbanizations, industrializations, as well as change in our food habits, along with cross-border trade, modern animal husbandry practices, all leads to break this, the theme like prevent, protect, and coexist, because all these factors are leading to a kind of critical situations like emergence of many infectious disease, which are at one point supposed to be handled efficiently, but due to several of those issues, they're kind of re-emerging. One of the examples that I can give you is the adaptability or the pathogen adaptations or evolutions of influenza virus. When influenza virus first time known for its devastating effect in terms of Spanish flu, we see there is a kind of millions of deaths. And that time there was a host specificity. But over the time, if you see the cartoon, you can understand that how this virus particularly changes their host adaptability. And now at least 3 species which are very key, swine, avian, and human, are equally susceptible to this particular virus, which is a factor for selective pressures, or I would say there are different human and animal husbandry practices are responsible for that. One Health issues is another important point, because it's a goal for the one of the goal of sustainable developmental goals, which is identified by the UNs, and we have a kind of 2030 goal, 2030 targets, year 2030 targets, where there are 17 total goals has been identified. Of them, one important goals are couple of important goals are right, poverty, hunger, and good health. On the other hand, they also identified these are the goals like responsible production in particular. So the question is how the increased production can be achieved without perturbing the environmental resource. Because if we want to solve the problems of hunger and poverty and good health, then it's not possible without making more. So if responsible production, I would say restricted productions, which can compromise to achieve these goals in certain time frame. However, UN also identified how these goals are going to be achieved together. So one of the issues which is associated with which is a potent limitations, or I would say challenge, is antimicrobial resistance. This antimicrobial resistance is also associated with different practices, which also the physical as well as the societal things. And that's the question is how this antimicrobial resistance among the pathogens which are zoonotic in nature, I mean those diseases which can transmit to human, to animal, or vis-a-vis, if we don't address those issues, these triads, human, animal, and health environment interface, which is the key for One Health approach, cannot be resolved, or problem cannot be solved. If you see the data, this is a very well-known data that the anticipated cost of AMR on health is around 5 million deaths, whether economically, if you calculate, it's near to the 100 trillion US dollar by 2050. This calculated anticipated cost is not exaggerated, it is there. So recently the World Health Organizations, UNs, and any other global institutions have observed a World Antimicrobial Awareness Week 18 to 24, and where it has been clearly mentioned that the caption was handle with care. So handle antimicrobials, specifically antibiotics, with care. So the how to take care means we have to find solution which can serve as an antibiotic alternatives. So how we can develop, or how we can utilize this platform, antibiotic alternative, by scientific community. So existing antibiotic alternatives, and which we all agree that these are the very common approach that we have been trying at our different trying at our end around the globe by many researchers, pharmaceuticals, and lawmakers in their own institutions level. So phage therapy, for example, then fecal microbiota transplantation, bacteriocins, pre or probiotics, effective vaccines and biotherapeutics, and of course, many of us know that plant origin bioactive molecules or materials are a very good alternative for antibiotics. If you want an example of how vaccines and biotherapeutics as an antibiotic alternative helps the mankind, we can always go back to the history, and you can see how many human diseases are controlled very effectively with the recent addition of polio global eradication initiatives. Similar thing prevails in animal health, where the vaccinations could able to save millions of cattle populations to provide safe and healthier cattle and meat food products, or any other form of dairy products. However, still the scientists, and as we do, that these are the different areas of disease, infectious disease, pathogens of which still to be resolved. Particularly, we do not have vaccines for H5N1, effective vaccines. We do not have vaccines for tuberculosis, malaria, Hanta, West Nile virus. So these are the challenges still we are facing, and we all scientists across the globe working hard to figure out how we can tackle those diseases, because antibiotics remains a conventional method to treating most of this bacterial disease. However, if we want to avoid antibiotic, we want to reach the goal like antimicrobial alternatives by 2030, vaccines, biotherapeutics, and probably these are the other options that we have. So how vaccine and biotherapeutics, can be effective in counter the spread of EIZDs? That is the terminology coined by World Health Organization and UN to identify the emerging infectious zoonotic disease, the key disease list of disease identified by World Health Organizations as well as World Animal Health Organization, World Organization of Animal Health. So as I mentioned before, what are the therapeutic options we have? Antibiotic alternative, bacteriophage therapy, probiotic-based therapy, cytokines or any other immunomodulators or the biological products that can help us to immunomodulate, and cell-based therapies, RNA biology, RNA-based antiviral strategies, and of course the enzyme-based therapies are currently under research, and many of those products are already in the market and in use. In terms of vaccines, starting from the Louis Pasteur scale vaccines to today's RNA vaccines, there are the different way that we can develop vaccines to target those diseases which are need to be addressed as soon as possible. So today's lecture will also focus something about how we can utilize the bioengineered probiotics, because we know that probiotics are good for our health, but a non-specific benefit that we can get like immunomodulations, increased metabolisms, increased absorptions, but how we can achieve a specific targeted benefits by using probiotics, I will also highlight during my lecture. So with this background, this is my this is the lab where I work, and these are the publications over the time we achieved. My research group, and this research is particularly, I'm very much thankful for IISER Kolkata for having a small animal research facility, which you can tell that it's a bread and butter for a scientist who works for infectious disease biology. And in addition to that, I have a very interesting facilities which is called Avian Research Facility. And most of the lecture for today's lecture, part of those basic science, basic knowledge that I'm going to try to provide you is based on some of the translational research as well. These two facilities are kind of very important for us. So as I said that my interest is host pathogen interactions. The reason behind that is the wide length of or wide coverage of our mucosal systems. So if you compare a mucosal system, if you hypothetically opens up this, it will cover almost 400 meter square area, which is close to small basketball ground. If we target those systems through the oral, then imagine how many organ systems we can actually cover. Nearly almost all the organ systems that we can cover if we try to use this mucosal route as a delivery of vaccines or therapeutics, or even understanding the pathogenesis of a wide range of microbes, which mostly majorly cover these areas. So in those systems, there are two states can be there can be two states. One is stage. One can be the normal state, like physiological state, where gut homeostasis is maintained by combinations of the mycobacteria pathobiont, microbiota pathobiont, and there is a homeostatic conditions, particularly the pH and other physiological factors, oxygen levels. But when there is a perturbations, either in a microbial community or in the induction of the physiological stress or other conditions due to many reasons, so there is a diseased conditions, so that can lead to disruptions of the mucosal integrity, so pathogen can enter inside the host cells, or there will be leakage of the bodily fluids, which creates all those issues related with gut diseases. So basically I focus on how in this system, like mucosal system, we try to understand the host microbial interactions, and second, more specifically, we try to understand how gut microbial secretomes on role in immunopathogenesis. So utilizing this basic knowledge by studying this two broad area, we try to translate this knowledge towards developing rational strategies to control mucosal pathogens in particular. So as I said, that secretomes, are actually tomes, means, there are vesicular structure, mostly we tell them, or secretomes, those are released by live organisms, is a wide, it has a wide range. If you confine, restrict to the gut, then if you see those, this is a kind of, if there is any gut disruption of the gut health, which is either caused or cause intravectal competition or interbacterial competitions within the gut, which leads to disruption of the gut, or which leads to the disruption of the homeostasis. So how it happens? Because most of the cases, pathogens either secretes, if they are pathogenic bacteria, they secretes a different secretion molecules through different ways. So one of the way they secretes their toxin factors is either in the form of exotoxins or endotoxins, but a specialized secretion system also engaged, which call them type 6 secretion system, type 1 to 7 secretion system. It looks like injectosome. So whenever they find the target, they carry the cytoplasmic content in a form of export proteins and enter inside the target cells to cause the disease or pathogenesis. Another form of secretomes are the extracellular vesicles, which are released by the gut microbes, where both beneficials and pathogenic bacteria, because secretion of extracellular vesicles is a biological process. It can happen without even any stress or even any type of induction or any type of exogenous forces. So it's a natural canonical end product for any physiology, any living creature so far. I'll tell what are those. So, and the other part is the bacteriocins. So they are generally released by the good bacteria. So good bacteria means huge populations of the gut bacteria, which are beneficial and considered as a common cells, and particularly those falls under the lactic acid producing bacteria produces a antimicrobial peptides in a form of metabolites. These are called bacteriocins. So today's talk is very much relevant to these extracellular vesicles. So I will cover extracellular vesicles. I'll give you a brief overview on how the biogenesis process using some cartoonish image. I will classify those based on their sources, whether it's a mammalian cells or it's a prokaryotic cells. Then I will briefly discuss about exosomes, which is a current emerging field and emerging tool for biomedical scientists to target disease or diagnosis. In the second part, I will cover extracellular vesicles released specifically by the bacteria, and I will try to give you a glimpse of how gram-positive and gram-negative bacteria's EV biogenesis is different fundamentally, and how we can utilize those EVs in a form of either exosomes or extracellular vesicles for biomedical research. So the first time the exosomes is come first, which generally described a long back in 1981. So Trumps and his team, first time they found that a wide range of cell lines, they secrete vesicular structures, which they are found both in the culture supernatants particularly. So they found that normal or neoplastic cells, they exfoliated some vesicles, and their size range is around 500 to 1000 nanometers. At that point, they found that they proposed that those exfoliated membrane vesicles are actually released because they have some intrinsic enzymatic activity. They term them, they are ectoenzyme basically. All those vesicles are associated with ectoenzyme activity. That time it was not found what are the active molecules or compound present within the vesicles that drive that ectoenzyme activities. And they also proposed that the name exosomes by Trump and this group. This paper was published in Biomembranes in BBA journals, and they also captured very interesting first-time electron micrographs of exosomes, which are present within a larger vesicles. So those dots are actually exosomes, and when they did for more higher resolutions, they found the individual circular vesicular structures, black in color, using probably immunogold staining. Sorry. All right. So that's why the exosomes, the biogenesis. So when you see there are different types of the vesicles can be produced by mammalian cells, either in the method of exocytosis, which the disruptions of a multivesicular body which originates from the cell membranes, or else they can be also termed as ectosomes. And also there are apoptosis, and then apoptic bodies can also be classified under the extracellular vesicles. But the extracellular vesicles within a particular way, when they biogenesis from the endosomes and fusion with the membrane, and then those smaller vesicles are specifically termed as exosomes, and that is entirely a part of that is entirely because of the size. Exosomes are much smaller, if you see even the cartoon, than the other type of vesicles. So for the sake of discussions, all are extracellular vesicles, but those which are coming out by the disruption or exocytosis of the multivesicular body, which is originally formed from the endosomes, are termed as exosomes. On the other hand, if you see the bacterial cell, a very superficial image of a bacterial cross sections, the gram-positive and the gram-negative bacteria, the difference between the gram-positive and gram-negative is that the special wall on the top of the outer of the small thin peptidoglycan layer, which is the phospholipids and glycopolysaccharides. So that's why it's associated with the outer membranes. So those outer membrane is absent in case of the gram-positive, which is primarily formed by the thick peptidoglycan layer. So these peptidoglycan disruptions leads to those vesicles. Then we call them bacterial extracellular vesicles. This is the classification that we kind of agreed upon by the researchers. And if it's released by the gram-positive, we term them bacterial extracellular vesicles. But if it is released by the gram-negative bacteria, because they comes out of the bursting and taking part of those entirely the outer membranes, so they are called outer membrane vesicles. So this is from the gram-negative bacteria. Now coming back to exosomes, so if you see, the exosomes are different size, and when the nomenclature was made, the size, based on the size, if you see the viruses, which falls within 330 to 100 nanometers, of course there are pox virus which is much bigger than that size, but the exosome actually falls within this range. While the protein aggregation or bacteria, as you can imagine, up to the 1 micrometers, platelets, apoptic body compared to that is really the higher in size. So their size is kind of this, and this is a mature cell which is 10 to 12 micrometer at max. So based on the size and the biogenesis process, exosomes are a bit different than the other vesicles or extracellular vesicles. All right. So what are the different steps involved in exosomes synthesis or exosome biogenesis? So as I said, the main organelles which is associated with the exosome formations is the endosomes. So normally the early endosomes, there will be starting with the plasma membrane invaginations, and those early endosomes they form into late endosomes. Sorry. So the late endosomes also further transformed. We call them intraluminal vesicle formations. So the late endosomes then inward budding inward side. It's not a outward bulging, it's an inward bulging, and this inward bulging inside the endosomes, or also we call the intraluminal vesicles, and then the whole endosome is actually called multivesicular body. Within this multivesicular bodies, there are the dotted, these small vesicles are actually the intraluminal vesicles, and they, when they at that point, all the cargoes like proteins, lipids, enzymes, they're all incorporated or adhered onto this with this exosome structure or vesicular structures, and then they're released, and first they translocate to the membrane again, and from there the membrane fusion, and those vesicles are then burst out or pinched off. Here the snare formation of different snare proteins are also involved, and finally when they burst out or pinched off, those vesicles are come out, and then exosomes can be released. So there could be two possibilities here. If those multivesicular body within which those intraluminal vesicles present, if they translocate or directed to the lysosomes, then endolysosomal fusion happens and they cannot come out, so they can degrade it. So they can have two fate. One, within the cell, it can either recycled through the endolysosomal fusion, or it can escape the endolysosomal fusions and can bleb out or pinch off from the host cell membrane, and then the smaller vesicles available in the extracellular environment. And throughout this process, the exosomes, throughout the process, the mechanisms we generally, it's well identified, and we call it endosomal sorting complex required for transportations. So this is escort mechanisms, and there are three steps mainly. The first step is the cargo selections, means what are the different cargoes they can be incorporated within those intraluminal vesicles, small vesicles of size 30 to 200 nanometers. So we call it escort zero stage, where most of the proteins get ubiquitinated and then they incorporated. And the second phase, the endosomal membrane budding inwards, it's not outward, as I mentioned earlier. Here, the SCOT1 and SCOT2 associated proteins are there. And finally, membrane scission by SCOT3 proteins that leads to release from the cell through the endoplasm, through the endoplasmic membranes. And finally, the secretions, as I said, or it can go for the degradations if they fuse with those these vesicles which are bigger in size, within which those small intraluminal vesicles are present. If they directed to the endosome, directed to the lysosomes, then they get degraded, and the other way they can fuse it, so and release it. So the lysosomal transportation can lead to degradations, but plasma membrane translocations or directions can lead to release the outside of the host cells, and we can call them exosomes. So exosomes in a common media, they have a lot of other vesicular structures as well, can come from different sources. So there are very established common exosome markers, and those markers are very well defined. So anything that is exosomes, they must have those surface receptors. So using corresponding antibodies, we can easily detect which are exosomes and which are not exosomes. So for example, CD90 and CD9, CD63 and CD81 are the three common surface markers, as well as there are cytosolic marker like SCOT associated proteins. And there are, of course, for the cancer cells, you will see a lot of EGFR, and stressed cells, you can see the heat shock protein markers, as well as from the adherent cells, epithelial cells, we can see many cell adhesion molecule as a markers. However, if those vesicular structures having the calnexin, or you can identify the calnexin or APO1, the most of them are negative markers. So this negative selection is important for achieving a purity of the exosomes, and there are many reagents, the combined reagents are available for enrichment of exosomes from a mixed populations or mixed source clinical samples. Now the next question is, why these exosomes are being produced? As I highlighted, the major functions are actually four. However, there could be many other small contribution at the level of cell-cell interactions. However, we can identify, we can broadly say that they are used for the cell-cell communications. They are the vesicles which also carry some key informations or cellular signatures which can lead some immunoregulations. They can also associate it with signal transfer from cell to cell. And of course, some agree with that. Some research suggests that they can also used as a waste disposal mechanism, waste disposal modalities. Now, once those exosomes are produced, what are the fate of those exosomes? So both slides are cartoons are more or less giving the same message, where it's being trying to tell that the exosomes, once they're released from the this big vesicles, and then through these are the intraluminal vesicles, when they present in the extracellular milieu or extracellular space, it could be urine, it could be blood, it could be cerebrospinal fluid, any liquids which are released by our systems, so rich in exosomes, and those exosomes can be uptaken by the cells if they are kind of antigen presenting cells, or for example, if you have dendritic cells or phagocytic cells, or even they are non-phagocytic cells. They can go through the different known pathway and uptaken by the nearby cells, and they can cover all the different pathways during the uptake process, like receptor mediated endocytosis or caveolin mediated, other micropinocytosis, macropinocytosis, phagocytosis, and interestingly, direct membrane fusions. So direct membrane fusion is the method how the virus can enter inside our host cells, because the membrane lipids of both our the target cells and the viral lipids are more or less very similar. That helps to create a lipid exchange or intermixings that leads to the direct delivery of those vesicles inside the cells. So you can imagine that if you want to target anything through those exosomes, it can adapt both pathways, either endocytic pathway or cytosolic pathway, to trigger or to release the content directly into the cytoplasms, to process through proteasomal pathway, or if it goes through endocytic pathway, leading to to the endosomal processings, and finally the cell surface display with, if there is a antigen presenting cells, then there are MHC class 2 presentations. So there is one example I'll just put how the exosome research helps for the diagnosis. So as you all know that there is a common disease, is a very rare disease though, is a spinal muscular atrophy, and it's found in an underage, in very early age in the baby, like 6 months old or less. And they have a specific protein, which is the protein which is mutated form, which is survival motor neuron proteins. And this is the major, this is the key protein that is associated with spinal muscular atrophy. And there are several types of SMA. SMA1 is really, highly dangerous, and it can cost the life of the baby before even grow beyond the year. SMA type 2 is a bit of less severe, and children usually survive and lead more or less common life rest of the time. And type 3 SMA is the most least severe type, and it doesn't have much complications. So chemically, how it is biochemically, the disease is associated with SMN1. It is actually the same protein because of splicing issues. They have two different versions. One is SMN1, this exosome 7, and this is SMN2, and this exon 7, there is one mutations. So due to this deficiency in full-length SMN protein, they cannot form due to homozygous deletion or mutation in this SMN1 gene. They lead to production of deformed proteins. So this is the deformed version of the proteins where this exon 7 has some mutations, and then these proteins actually very unstable compared to normal SMN1, the normal SMN proteins, this low level of SMN proteins, and because of their instability, and they are unable to function like the full-length proteins, which give the muscular strength, spinal cord, to maintain the spinal cord strength. So that doesn't that is not being provided by this SMN2, the mutated or altered version of SMN1 proteins. So first, it was found that the SMN protein was expressed in different cells as well as their extracellular environment. So there are a number of cells. This is a study published in scientific report in 2017 that a large number of cells they produced by this particular proteins, and they also found that this protein can be recovered from the cell supernatant, culture supernatant. So in the next step, what they did, they tried to isolate those extracellular vesicles from those culture supernatants, and they perform Western blot as well as the immunogold staining for better resolutions, and they could find those small, tiny, black color, immunogold stained vesicles, which are very similar to, and compositionally and chemically is very similar to the SMN protein, which is found inside the cells. So from this study, it is very clear that for the diagnosis purpose, even the culture supernatant or spinal fluids can be easily helpful to detect this protein. So without any invasive methods for detection or diagnosis, this could serve as a very quick, precise, and accurate diagnostic methods where EV can contribute, or extracellular vesicle, particularly exosomes, can contribute to this. In fact, the salivary exosomes also is important clinical samples for clinical researchers or clinicians to diagnose a wide range of disease, including Parkinson's disease. As many of you must have known that the Parkinson's disease, the Lew protein, Lew bodies, it's a protein, altered protein, normally overexpressed, and it can be found at different places, so different locations. However, a group in, I know personally that group in AIMS Delhi, they are working with this Parkinson's disease model and exosome-based diagnosis. They collect the salivary secretions, and they could easily see those exosomes can carry those Lew bodies. So imagine how easy it is, how convenient, and how precise it is if we could found in exogenous fluids or extracellular fluids. If we can collect those samples and detect the right way, then nothing can be better than this, because this is a purely non-invasive methods of detections, and you can also see many other confirmatory markers for particular disease if they carry those signatures in the exosomes. With this, I will move to bacterial extracellular vesicles. All the exosomes, whatever the slides I presented is, I prepared those. None of the area I am working with exosomes. However, my more comfort zone is with bacterial extracellular vesicles. As I was mentioning earlier, that bacterial extracellular vesicles, or in fact all the vesicles, are naturally derived, nano-sized, canonical end product, and bioactive membrane-bound vesicles, which are released by a wide range of sources like archaea, bacteria, and eukarya, so as well, which includes mammalian cells and the plant cells. So it's kind of ubiquitous and physiological end products, we can always say. So exosomes research in bacterial, particularly from the bacterial side, is not very new. The first time the outer membrane vesicles or the bacterial vesicles was detected by two famous scientists, which are luckily, we are proud to say that these from Kolkata, tropical medicines, Dr. S.N. Chatterjee and Das. They first working with Vibrio cholerae, and when they grow those bacteria and collect those culture supernatants, they found some sac-like bulgings in the bacteria, as well as they isolated by uranyl acetate staining, isolated and stained with uranyl acetate, and perform the imaging, and they could see those vesicular structure. At that point, they termed them as sac-like structures. So and it moved this research, this important observational findings further escalate the research in the history in the extracellular vesicle biology, which for the next study in 1990s, where it was found that those extracellular vesicles can also encapsulate or carry some of the genetic informations. For example, there could be possible DNA or a fragment of DNA, RNA, even microRNA. They are all encapsulated on those exosomes or AVs, which can clearly tell the key informations about their parent cells. It's a bacteria, or doesn't matter, it's a mammalian cells. So the history, once this groundbreaking observation was made in the 1987, the first content analysis was performed. So what is the compositional attributes or aspects of those biological bacterial extracellular vesicles was analyzed. For this first time, Gamazo and Morion first used Brucella melitensis, a gram-negative bacteria, normally attacks sheep, and they are very dangerous disease pathogens for them. And they isolated those vesicles and they analyzed the content in terms of protein, carbohydrate, and the lipid mainly. The next decades, the next 2 decades, 1990 to 2010, mostly people or scientists are engaged to identify how they are getting released. What is the biogenesis process, as well as what is the models for the functional aspects of those vesicles. Why do they produce from the cells? And in 2010s, this decade, Also, it includes most of the cases application studies. So there are several groundbreaking, observations and products are currently available: exosome-based drug delivery vesicles, exosome-based or the vesicle-based vaccines. They're already in the market. One example is, so those vesicles also helps to, as I mentioned, that this group led by Saroj Kumar, they identified unique methods to diagnose the neurodegenerative disease, including Parkinson's. And then the vaccines side, there is the one vaccines which is known as marketed by GSK, which is Bexero, which is a meningococcal group B vaccines, which is a purely exosomes, particularly extracellular vesicles, bacterial vesicle-based vaccines. And important that these vaccines can be given in much elder age. Sorry, it's not like generally these vaccines is given to 0 to 10 years within span, but it can go beyond that, like 10 to 25 years age also can receive these vaccines. And it's a very popular vaccines in most of the Europes and UK. To discuss the OMP biogenesis and with example of how they can be utilized in a modern biomedical research, I identified, I will give you a glimpse of two different bacteria. One is Lactococcus lactis. As you know, this is one of the probiotic bacteria. Many feed supplement, milk food products, they're included into it because they're milk fermenting bacteria. They can also release a lot of bacteriocins, bacterial metabolites, or antimicrobial peptides. It's mostly the niacins, and those bacteria, how we know that they are gut microbiota, part of microbiota, and they help for non-specific health benefits. But I will try to show you how we can utilize this as a source of extracellular vesicles. On the other hand, there is a pathogenic bacteria which is gram-negative in nature, Campylobacter jejuni, which is one of the neglected pathogen till last year. But recently, in 2025 March, there was an outbreak in Pune first, and then many places in India, including Kolkata. There are cases of Campylobacter jejuni associated disease, which is known as Guillain-Barré disease, was detected. And this is the overall data, that is 300 cases of 21 dates nationally was reported by Ministry of Health and Family Welfare. So which raises the many concerns for this Campylobacter jejuni. The primary host for this bacteria is chickens and domesticated animals. So they can, in addition to gastroenteritis, which is a common outcome of Campylobacter jejuni transmission to human, but there are extra intestinal complications like, as I mentioned, GBS or Guillain-Barré syndromes, reactive arthritis, and also IBD, bowel disease, irritable bowel disease. They also contribute to those diseases because of their specific structure of their outer membrane, which is enriched with lipo-oligosaccharide, is a human mimicking structures, which leads to autoimmune antibody against our ganglioside, GM2 and GM1. But this is a very classical, I took it from, I don't know, maybe wiki or somewhere. So just to let you, just to make you, understand that how the cell wall outer membrane is different from each bacteria, for better understanding of how the OMP biogenesis happens differently between these two bacteria. So the peptidoglycan is the major thick outer layer for this gram-positive bacteria, which is the outer membrane, which doesn't have any outer membrane. While in case of the gram-negative bacteria, in addition to have a thin layer of peptidoglycan, they have a outer membrane lipids. In the presence of outer membrane lipids, which composed of lipopolysaccharide in general. So most of the gram-negative bacteria have the lipopolysaccharides. However, this Campylobacter jejuni has little change, where they have lipo-oligosaccharides. And this is the the O-specific chains, and these membrane to embedded portions are mostly the lipid A portions of the lipopolysaccharide, and this lipid A portions which is embedded and not embedded, which is in the C terminal close to the membrane, is highly endotoxic. So whatever the endotoxicity exhibited by lipopolysaccharide or lipooligosaccharide is because of the lipid A portions. And Campylobacteria have this lipid A structure very similar to our nerves, neurons, and neuronal lipid structure, and this ganglioside, particularly ganglioside, and they mimic the antibodies which degenerate the our neurons, and that creates the problem with neuronal disorders, leads to GBS or Guillain-Barré disease. Now, with respect to how these vesicles are released by a gram-negative bacteria, there are three different hypotheses has been given by many groups of scientists. And one of them is loosening of this outer membrane and peptidoglycan, the thin layer one, the thin one, the releasing of this cross-linkage. So once this cross-linkage is not enough, and this kind of lacks this cross-linkage or loosening, there is a membrane bulge starts, and those bulging out of the outer membrane at the end of the day leads to vesicular formations and released by the bacteria. The second hypothesis is the involvement of different quorum sensing proteins. So one of the known quorum sensing is Pseudomonas quorum sensing proteins. This is intercalation molecules. So if they are accumulated in larger amount or expressed in higher amount, that can also leads to the turbulence of the outer membrane, which can finally helps to bulge or pinched off those extracellular vesicles to the over time there are misfolded proteins and metabolites, they get lodged into those empty space, and that create also the explosive cell lysis, and this is that can also leads to the misfolded protein and burst out. And the final one, which is the very recent hypothesis, by the endolysins, first derived endolysin, which helps to burst out the outer membrane. So that's called outer membrane vesicles released by the explosive cell lysis. So that's the latest hypothesis that has been provided. Okay, so in case of the gram-positive, because they don't have an outer membrane, so majority of this case, the first derived endolysins remains the major factors because of this thick peptidoglycan is often very difficult for the gram-positive bacteria to release the cytoplasmic vesicles or the bacterial extracellular vesicles, and often they are very scanty and very low numbers of vesicles could be found in the culture media of the gram-positive bacteria because of the bursting out or making way out to come out of the external environment by even by the endolysins to rupture the peptidoglycan bilayer seems to be a bit challenging or difficult for gram-positive bacteria. So, as just mentioned, that Campylobacter jejuni is a chicken pathogen mostly, not chicken source. So chicken remains as a source for this bacteria, and they do not show any visible lesions. So this is the two different image. One is with chicken cells, another with the human cells. Same number of bacteria causes a lot of disruptions in the cellular architecture of the human intestinal epithelial cells, where they kind of adhere, but they do not do any specific pathogenesis or changes in the cell in case of the chicken cells. So that's that says that chickens are kind of resistant, or chickens in chicken system they live well, while in they coexist in human system they affect the epithelial cells, so that and causes a lot of complications that I just mentioned in my previous slide. On the other hand, the Lactococcus lactis, the first genetically modified and generally recognized as a safe for human consumption bacteria. They have a lot of benefits. I'll skip that. So now, once there is a stress, either it's a form of loosening of the peptidoglycan and outer membrane loosening, or peptidoglycan LOS bondage become loosened, or by the endolysins, or by the accumulations of the misfolded proteins. The bulging out is in resting stage, and then there is outward bulging, and either accumulated all those cargoes, they're released as a separate entity. And those cargoes, those vesicles, if we analyze, there is a number of different chemicals composition. The compositional diversity is huge. They can carry from small proteins, degraded proteins, to many genetic materials as well. Mostly those are not intact though, the genetic materials, but they have all sorts of DNA, RNA, enzyme, phospholipids, periplasmic proteins, even the toxins, and many cytoplasmic proteins. So now the question is, once the vesicles are produced by the bacteria, what is their role? As I said, they help for the cell-cell communications or host microbes communications. So how these communications is generally established. So that's why we need to check how actually they interact. When they interact with the cells, where do they go? What is the fate of those vesicles? So to understand this whole vesicle biology, these two equipment is very important. One is nanoparticle, both are nanoparticle tracking analyzers, and they help to quantify and they help to determine the purity, size, surface charge by this particular model. On the other hand, this is another updated model by different company, which is particle matrix. In addition to providing all those three different features, they also able to quantify the vesicles, and they also helps to study the vesicle interactions. So that is a kind of interesting, and our lab has both these facilities. So if any one of you interested to know utilize these two machine for your nanoparticles or even the exosomes, I'm happy to help. So this is optimal protocol. So I will share the slides. You can check. And these are the vesicles image videos are captured by those machines, which clearly says that the vesicular structure are not uniform. They are heterogeneous in nature. Even that was further verified by, these are all gram-negative bacterial vesicles. They are of a bit of wide range, but not as wide as the apoptic bodies. So the size range, the mean is kind of 100, but the range is from 20 to 700 nanometers. And that is consistent with many, the diagnostic, many analytical approaches like DLS, transmission electron microscopy, as well as the zeta potential, the surface charge, because they are originated from the gram-negative bacteria. And as I said, the lipopolysaccharide is always present there. So it is obviously a negative charge. So minus 19 or 20 millivolt in together. Compositionally, if we see a specific number of vesicles, if we count, then the part of vesicles, the microgram of the proteins, which is can be calculated by very simple assays. Carbohydrate content, what we found that 1.81 per microgram of the protein, total protein associated with the outer membrane vesicles. So they have also reached with lipids. And of course, the main key thing is the lipooligosaccharide, which I just mentioned, that without this lipooligosaccharide, the vesicular structure probably cannot be formed. So there is no way that you can remove all the LOS from those OMDs, then the OMD structure will be collapsed, or you may not be able to have the vesicular structure, a key part for the drug delivery systems, key attributes for the drug delivery systems. So as per the EU, we have endotoxic unit, which is 0.09, and the approved unit for any biotherapeutic use is 0.1. I'm not very sure, I have to double check. It's a little bit higher than the one which we found or generally found. So, but still it's a kind of perception, any vesicles that having the endotoxic units like LOS, it's very difficult to get the legal approval for drug development or vaccine development research. All right. In terms of proteomics analysis, because as I said, they have reached a wide range of proteins, subcellular fractions, including periplasmic, membrane-associated, cytoplasmic, as well as toxins, secretion toxins, and endotoxins. So exotoxins or endotoxins, in particular gram-negative. So most of them we got about endotoxins, but they do have some secretory effector proteins which can serve as a very important export toxin systems like type 6 secretion system, which release hemolytic toxins as well. So we could still find that there are some toxin component along with 65 different proteins are found in those vesicles. So my point is those vesicles are rich in lipids, rich in carbohydrate, rich in lipooligosaccharide, rich in different genetic materials as well. So if you imagine a vesicles, the vesicle is probably a miniature of a non-living bacteria. So the concept of killed bacteria and the concept of killed bacteria can be further improved if we can have those membrane vesicles and use them as a therapeutic cargo or as a vaccine delivery mode, because they entirely have a miniature of the bacteria which is non-proliferative. So I'll just keep that slide. So now, for scientific, for immunological purpose, why we are interested to see why those outer membrane vesicles are important. So we try to see or understand how those vesicles are getting inside the cells, as I mentioned in the previous slide. So for that, those OMPs can be labeled by any chemical conjugations. So we used R18. We used R18 to label those OMP. Any lipophilic dye you can use. So using those dyes and co-culturing with the different cells, either in a concentration dependent manner or in a time points. So this is the concentration dependent addition of R18 labeled extracellular vesicles collected from Campylobacter jejuni, suggests that it's a kind of increasing the intercellular accumulations. The green color is basically the R18 labeled OMVs, so we can increase. We have the increased uptake within the cytoplasms, and this is also we have seen in different cell lines, which is chicken cell lines, and most of the cases we can also see that the increased concentrations enhances better uptake, enhanced uptake. However, when you see the time kinetics, means how long it's to take to get complete internalizations of the vesicles, the similar approach we adopted, and we can see that the green signals is much enhanced over the time, but at certain point they kind of saturated, or most of the vesicles are now internalized. So these primary chicken cells and the human Kakutu cells both are epithelial cells, and it suggests that they can be uptaken by the non-immune cells like epithelial cells. But what is the mechanism of this uptake? So this mechanistic study is pretty optimized study for different purposes. We can utilize the same models. So there are many chemical inhibitors which can block each of those common pathways. For example, if you use dinosaur as a chemical which can block the clarithrine and both caveolin mediated endocytosis. If you pre-treat the cells with nystatin, it can block the repeat lap mediated endocytosis, while if you use cytogelasin or amiloride, they can block the macropinocytosis because they prevent the actin polymerizations. So now if we use OMVs or extracellular vesicles to the cells which are pre-treated with all those chemicals, we can clearly see determine which pathway actually they are uptaken by the cells. So it was found that for human epithelial cells, the major pathway involved, because if you see the dinosaur, there is no OMVs or no green signal inside, means there is a nearly almost complete blockage of the pathway, which doesn't allow the OMVs to enter. That indirectly says that the OMV uptaken process is basically dynamine dependent, like clarithrine or caveolin mediated. Rest of the other pathways, although they are contributing much lesser in terms of intensity as per the flow cytometry data suggest. Similar thing we checked with chicken cells, and mostly if you see that in human CACO2 cells, the nystatin, amiloride, and cytochalacin, the blockage mostly happen in the dinosaurs or diamine-dependent pathways. Similar thing is found in case of the chicken cells as well, but here the cytochalacin also is higher, so there is no way that it is little bit also blocked by cytochalacin D. That means the macropinocytosis can be the other uptake pathway for these OMV-like vesicles. Now, this is all about the endocytosis. What about the cell-cell fusion or cytosolic uptake? So for that, this is a freight assay. Many of you know about this assay. It's a very simple, assay, optimized assay, utilized for membrane fusions where there is a hemifusion or fully fusions. The principle behind this assay, this is the fluorescence resonance energy transfers. It depends upon the two fluorophores which can transfer the energy to the other. So we use GFP and MCHD for example. If those two fluorophores are close enough, then only the freight transfer happens. So if they're physically apart, then that doesn't happen. That is the primary thing. There will be no interaction could be found. And the second, when you choose for those fluorescence probes, the probe important because the excitations and the emissions, this should be the emission. The excitation, for example, NVDP, which we use to probe the OMVs, the excitation is 468, but the emission is 535, which is overlaps with the excitation of the acceptors. For example, here we used artificial vesicles, liposomes. So that is important. So the emission of the donor must overlap with the excitation range for the acceptor. Here, for example, here is the liposomes, which is probed with the rhodamine PE. So utilizing these basic principles, when we see this freight assay, including the dye dequenching and content mixing, we can clearly see that those vesicles are able to fuse with the membrane. If the data indicates that they have the ability to fuse with the membranes. So that means a lot for a vaccinologist who try to develop vaccines which can involve both pathways like cytosolic and endocytic pathway to give a broad immunities. So far we easily can say that it is not a simple byproduct of bacteria. OMPs have specially designed by the bacteria for the host. So throughout what we discussed is that the biophysical attributes of the outer membrane vesicles, how they helps to facilitate bacterial adhesion because they contribute to the bacterial pathogenesis and the uptake process. So that says that cytosolic pathway and endocytic pathway, they can be uptaken by both pathway, and that can contribute to design next generation vaccines, and possibly they will be much more effective than other methods because they are biological products. They maintain the membrane structures and content of those vesicles are highly versatile and heterogeneous. How much time I have?
Sir, you have 25 minutes.
Okay, thank you. In the next, so that was the that is the basic, how fundamentals of how OMV is generated and how OMV is being utilized by the host cells, or why bacteria produces outer membrane vesicles. Now, how we can utilize this knowledge towards a translational science. Being a translational biology, I'm always interested to see the other aspect of any basic observations. So for this reason, and also as my title also says that what is the applications in the biomedical research, that OMV can be a defensive custodian for the host. That means host can utilize OMV as a mode of inducing immunity against that particular pathogens. So for that, of course, an animal study is required. So the purpose of that is to see whether those OMV or those vesicles, once they delivered inside the host, whether they can induce a comparable immune responses, and whether the immune responses generated by those vesicles are functional or not, whether those antibodies effectively reduce the bacteria against which we are trying to develop a vaccine or against from which those OMPs are isolated. For example, here we isolated the bacteria or outer membrane vesicles from Campylobacteria. So we wanted to see whether those vesicles, if we immunize the animals, whether they can induce an antibody response which is functionally active and reduce the bacterial ability to adhere to the host cells. Since it's a gut pathogen, so our main target was to develop vaccines which can be delivered through the mucosal or oral routes. So as you can understand, oral route of administration of any nanoparticle, either in the prophylactic or therapeutic applications, is very challenging because of the gradient of pH, harsh environment, and many proteases and other activities are there which reduces the shelf life of the nanoparticles, and sometimes premature degradation happens. To achieve that, we just coated those outer membrane vesicles for a very simple reactions using chitosan as a polymer, biopolymer, which is a mucoadhesive, known properties, biodegradable. It doesn't have any immunogenicity, but it enhances the absorption in the epithelial cells, particularly the microfold cells. So using this, we use both mice as well as in chickens. So we did the immunization study, and what we observed that if we collect the antibodies against those OMV immunized animals, they increase the level of IgA response in the intestinal lavage because those are gut pathogens. So systemic antibody may not be very may not correlate with the functionality. So cecal lavage or gut lavage, intestinal lavage, to collect the secretory IgA much more relevant or rational. So what we see that there is an increase in antibody responses in the gut. Also, we check in the freshly collected fecal soup the antibodies, and collected those antibodies, harvested the antibodies from the feces, and we also check that this is the chitosan OMVs. This can increase the antibody response. And the last group is the incomplete ference adjuvant injectable vaccines, which is a positive control. So that says that it is raise the antibodies in the local mucosal surface, but whether those and also what we see that they can also reduce if we challenge those animals with the bacteria after the immunizations. There is a reduction in cecal load of this bacteria. That means indirectly we can tell that those antibodies can neutralize those bacteria so that they could not adhere. They cannot adhere to the epithelial cells to enter inside the epithelial cells, and they can be probably released by the feces. So that suggests that oral immunizations of outer membrane vesicles can be a very good vaccine candidates as is. So particularly in the mucosal surface. We do not know whether if we inject to the intravascular, intramuscular or intravenous, what is going to happen. Most likely the liposome, the way liposomal vaccine works, they should work, but it depends upon the target pathogens, whether it's a blood parapathogens or it's a systemic pathogen or it's a local or mucosal pathogens. So what we see by in vivo study, that local and systemic antibody responses with a mixed type, total, there are some cellular responses we got. And finally, the important parameter is the reduction in the cecal load of CJJ challenge. All right, but the problem has not been solved. What I mentioned that the endotoxic effect is still there because we cannot administer human with a kind of endotoxic containing materials, biological materials. So the injectable drugs, the permissible limit is 5 EU endotoxin unit per kg body weight per hour, while in intracranial or intrathecal is only 0.2 EU per kg per body weight per hour. So that means that one must be very careful and about their product or about the exosomal use bacterial vesicle use for either as a therapeutic purpose or as a vaccine purpose. So we need to find out the way how to neutralize this LPS or how to reduce the functionality of this LPS so that the endotoxic effect is minimal or low. So there are several approaches are there. So one is the genetic, one is, the possible approaches could be, select the strains of the bacteria which lacks ganglioside mimics, for example, C. jejuni. We can use some serotypes which lacks the ganglioside mimics, so autoantibodies, even the form, they will not cross-react with the ganglioside. Second could be the neutralizing the lipo-oligosaccharide prior to injecting those animals. And the third, genetically detoxification, do some modification in the LOA structure so that it becomes functionally inactive. And the fourth could be use a probiotic, a completely different bacteria as a source for EVs, because gram-positive bacteria doesn't have LPS, so there is no risk for the endotoxicities. So with respect to the genetic mutations, the several target genes are available, and there are some studies which showed that targeting this lipid A, actually the lipid A, and this is the inner core and the outer core of the lipo-oligosaccharide leaflet, and the lipid A is generally hexaacylated. Among them 1, 2, 3, 4 are the primary chains, and there are 2 secondary acyl chains. This hexaacylated form is highly important for lipid A functionality, because this lipid A with this acylated form is bind to lipopolysaccharide binding proteins, which is expressed on the cell surface in association with a CD14, which is helping the TLR4 activity along with the MD2 for pro-inflammatory signals. So this is the normal signals generally happens if the LPS is in full form. Lipid A is a non-mutated form or full functional form. So that leads to different inflammatory cytokine expressions, interferons, inducible genes expression, which ultimately leads to endotoxic shock. But it has been found that if by some mutation can do some mutation, if we can do, then if this hexaacylated forms, if changed into penta or tetraacylated, the ability to bind to the lipopolysaccharide binding protein is majorly reduced. If they do not reduce, the MD2 TLR4 joint activation for the TLR agonistic activity of this compound become really low, and there is no pro-inflammatory signaling it could be seen. So that is shown in case of the E. coli. There are several literature, particularly this ACS chemical biology paper suggests that modifying them into tetraacylated lipid A in E. coli lipopolysaccharide can reduce the endotoxic effect is a greater extent. So that is one option. The second option is the chemical treatment, which is more superficial and more far easier than the genetic mutations. So there are several chemicals which can inhibit the lipid A activities. On the other way, they block the lipid A from being bind to their ligands. So one of the antibiotic is polymyxin. So polymyxin is a common antibiotic generally given in case of there are infections in the drug resistant infections. So polymyxin B is a cyclic polycationic peptides naturally produced by Bacillus polymyxa. But this drug is not a drug of choice by the many clinicians because it has a high nephrotoxicity, and also I think it also have the hepatotoxicity. I'm not very sure, but they get a lot of nephrotoxicity. So particularly polymyxin A is kind of very restricted drug. But polymyxin B, on the other hand, it is still in use. It's a highly positively charged, polycationic peptides, and that's why it can bind highly negatively charged lipid A portion of the lipopolysaccharide. So here, the lipid A portion, the polymyxin B, they can bind to those LOS, particularly the lipid A, which is membrane proximal part of the lipopolysaccharides, and those binding can help to prevent the interchain bondings, and there are some breakage can be possible in the outer membranes, as well as they can also penetrate the outer membranes and enter the inner leaflet, and then in both way they make kind of a breakage of this continuity of the polysaccharide structures, which helps the endotoxic effect kind of very low, because they're really attached to the membranes, and this is the way generally they kill the bacteria as well, because they create the pores. But if we use the polymyxin B in a therapeutic dose, then the bacteria will die, and those vesicles, there will be no way that the dead bacteria will produce vesicles, or there will be other issues. So we do not need to kill the bacteria. So polymyxin B optimal dose, if we can use, just to block those lipid portion, so that the vesicles, whatever they will produce, will be left with blocked polymyxin B, and the function of the lipo-oligosaccharide cannot be full or cannot be achieved. So with these principles, we started few things. Means we also tried those, how to chemically treat and make those OMVs. So basically, we use those chemically treated LPS. Let me see. Yeah. So I reduced the slide, deleted one of the slides. So what we tried to see, that we first treated those outer membrane vesicles with those polymyxin B, and collect those vesicles and treat the chickens with those vesicles, and try to see whether they can have the pro-inflammatory effect or not. And we observed that the antibody responses, which slide I am not I'm missing here. So what somehow I missed that slide. So what we tried to see in vitro, that utilizing this polymyxin B treated OMVs, if we charge a particular cells, either human cells or chicken cells of macrophage origin, we see a clear downregulation of TNF alpha, which is a major endotoxic markers, interleukin 1 beta. So that says that optimal treatment of the polymyxin B to the OMVs helps to reduce the endotoxic effect in terms of those markers like TNF alpha or interleukin B, compared to the pure untreated OMVs. So that suggests that could be used for another method to neutralize the activity of the LOS, and utilizing those LOS, utilizing those PMB treated LOS, we perform a full-length animal trial to see whether, because if you completely block the lipid A, the LOS activity will not get, but whether that OMVs can be a good immunogen or not. That we try to test, and what we see, that this even doesn't matter if you treat or untreat, we can still achieve a comparable response. That means to us that polymyxin B treatment of the OMVs can, although effectively reduce the LOS toxicity, but they preserve the vesicle structure and the immunological correlates of natural OMVs. So that would be one of the options to chemically neutralize and use them for vaccine candidates. But that again is not ensuring the absolute safety. So the last approach that I'm going to show you, whether the probiotic bacteria can be used as a source bacteria as a LPS-free extracellular vesicles. So for that, the use of probiotic, that is a very well-known fact, and we practiced and we use a probiotic for many purposes. So probiotics have the natural adjuvanicity, their absence of endotoxic factors, no virulency molecules, cost effectives. But the problem, the roadblocks of the probiotics EV is that I mentioned probably in the very first slide, that because of the thick peptidoglycan, the OMV output is very low. Therefore, there is lack in standardized methodology. The limited information on the structural functional aspect of EVs, and we do not know how those vesicles can be generated despite they have the thick cell wall. So again, these are the few things. These are the vesicles. Naturally, we see that those small budding out things are actually the natural vesicles secreted by the vesiculating bacteria. So for that, we utilize another interesting approach, because we see that microenvironmental stress like pH, growth media, temperature, antibiotic reports are there. They can influence the peptidoglycan or cellular not only peptidoglycan, but also the cellular integrity for the bacterial cells. So we chose to use antibiotic, a very simple antibiotic, which is beta-lactam antibiotic ampicillins, because ampicillin binds to the penicillin binding proteins, which helps for the biosynthesis of the peptidoglycan. So we thought of, by using a suboptimal dose of ampicillins, if they bind to the penicillin binding protein, the peptidoglycan biosynthesis can be blocked or inhibited. So that may, if you use higher amount, they can lead to the bacteria, but optimal dose, can they produce more OMVs or more bacterial extracellular vesicles? But as I said, that for the gram-positive, the terminology we use is bacterial extracellular vesicles, not outer membrane vesicles. So we optimized with different dosage and with other antibiotics as well. The protocol is very simple: treatment and then ultracentrifuge of the cell-free supernatants, and you go for MTA analysis, nanoparticle tracking analysis, compositional analysis. So all that is found that suggests that if you treat with ampicillin in a suboptimal dose, the EV number increase. So the protein, carbohydrate, lipid, and sufficient peptidoglycan is present. But if you use a chloramphenicol, it's not a good antibiotic because it inhibits the protein synthesis of the bacteria. So protein machinery, if synthesized, the bacterial survival rate is compromised heavily. So using this, we use to check again the similar way that how those extracellular vesicles can be utilized. So here we just try to show you how they can be utilized as a drug delivery vehicle. So there are several drugs we have chosen. One is doxorubicin, to check whether these vesicles can deliver doxorubicin to the cancer cells, and the method is the electroporation. And then we passive loading of amphotericin B, an antifungal antibiotic. We loaded onto the BVs and checked it against the yeast cells like Candida albicans. And then again, gentamicin, an antibiotic, we encapsulated into the BVs and checked against the bacterial infections. I'll just skip that. So we checked all three bacteria. One is gram-positive MRSA, methicillin-resistant Staphylococcus aureus, C. albicans, C. jejuni, and we also checked the anti-proliferative activities. So for anti-cancer activity, we check the clonogenic assay, perform the clonogenic assay, cell migration, because these are the common assay system or parameter that one can check for any anti-cancer drugs or even nanoparticle-based drug delivery strategy if you want to check in vitro. So the cells only, there's a cell migration. So if there is a stop, that means the proliferation is being inhibited. So in case of the cells only, over the time, this gap is being covered. While in the doxorubicin alone, or doxorubicin encapsulated within the BVs, so more or less similar features, because free dox, of course, means readily available. But our point was to show that whether the BVs can carry the drug in a comparable way like the free drug can perform. And we can clearly see that this closure of this scratch is much more efficient in case of the dox BV than even the doxorubicin. So it is slower, but here it is a very fast process, because we do not know that it has to be understand in other methods. So we also checked the which cycles, actually cell cycle, they are arresting by using BV docs. And we see that BV docs, the cell cycle arrest mostly happens in the G0, G1 phase, and versus G2M phase, which is normally doxorubicin is a pretty standard that they block the G2M phase. This can also be reflected in live versus dead staining. So where green AO, acridine orange, the live cells, if you see the image, and then there's a red image, which is the dead cells, and this is the merged, this is the apoptic cells. So these three cell populations, if we compare the doxorubicin versus dox, almost they're comparable. So it can be concluded that they can be a carrier for the anti-cancer drugs. Same thing, we tried with the amphotericin B and checked with the Candida albicans, and we see that there are cell deaths in both, Candida albicans EVs and Candida albicans treated with only or free amphotericin B. Exactly similar phenomenon we see in case of Campylobacter jejuni when we use gentamicin as a drug of choice. And then in both cases, we see some cell death, is a huge death in both cases, like gentamicin alone or BV encapsulated gentamicins. So all that tells that this next generation all that tells that a targeted benefit, all that tells that OMV, BEVs or OMVs can be utilized for therapeutic cargo. But the limitation is that if we keep a gram-positive bacteria as a good bacteria along with them, they cannot do the targeted they cannot do the selections. So targeted delivery by OMVs is now, major questions how we can make them targeted nanoparticles so that they can target the particular cell types. So for that, there are option is to, we can bioengineer those BEVs. So that's why the caption says that next generation bioengineered EVs as a mucosal delivery platform for against pathogens. So one approach is to, we can always modify those bacteria, the source bacteria, by doing some extra chromosomal or chromosomal modifications, so that the EVs will have the desired proteins at the different subcellular locations. So that could be another approach to how the next generation EVs for targeted delivery can be synthesized and utilized. So for that, we also started some preliminary work that using E. coli as a systems. So we use the double transcription, co-transcription of two different plasmids. One will express the protein onto the surface, another will express the protein facing towards the periplasm. So it looks like this. The signal protein here is the CLIA and OMPA, these two protein of E. coli. If you fuse with any target proteins, for example, here we use M2 proteins, that helps to express the protein in a specific locations. So OMVs in specific locations. So OMV once brought out, they can have inherently associated with those proteins because they are all peptidoglycan anchored motif or peptidoglycan anchored proteins. So we tried to do this kind of co-transfection study using a probiotic strain of E. coli nasally strains, and we checked the OMV output and see the size, and there is not much difference. So hydrodynamic diameter of hybrid OMVs, which have both proteins, except one in the surface exogenously, another is the another facing inside the periplasms. So both cases there is not much different in size, and we are successfully able to generate those hybrid cells having both expressions. And these are the image.
Excuse me, sir.
Yes.
Kindly conclude within 5 minutes because time is over.
Okay. I'm almost done.
Okay,
so
sir.
this is the way that we can try to design a bioengineered EVs for targeted benefit. So far, what we discussed is an optimized enrichment protocol for EV biogenesis from the Lactococcus lactis. We provide detailed insight into the morphological attributes of the BEVs and functional attributes and potential use of BEVs as a safe natural nanocarriers for the drug delivery systems. And in addition, I tried to display some of the interesting approach, one of the interesting approach that how we can generate a bioengineered EVs by molecular picking of the source bacteria by simple methods like introduction of new plasmids, one or double plasmids. Particularly, you have to look for which location you are going to express the proteins. So most of the cases, surface display would be the much better because they are more accessible. Even though OMV biogenesis happens, the OMV can display those proteins onto the surface. If those targets are identified, they can easily bind to the ligands for the targeted cells or host cells. So currently, we are also studying how this MLA system, lipid asymmetry systems helps for the OMV biogenesis and trying to develop vaccines which can be commercially viable. With this, I will I would like to extend my thanks to my students, my collaborators, and one of my project collaborator who is located in UK, and the funding agency like ANRF and DBT. I am also working in the different areas with my chemistry colleagues and some environmentalists, scientists. So we do a lot of AMR profiling, in vivo wound healing model, antibody generations, PDTs. So these are the things I do in collaboration with interested colleagues. With this, I again thank you all for your patience and giving me the opportunity to discuss this topic. Thank you.
Thank you very much, sir, for your very insightful talk. Now we would like to open the session for question answering.
Sure.
Uh, uh, I request all the participants, please, before asking the question, state your name and your institution name. Before that, I have received some questions in my chat box. Let me ask to sir.
Sure.
Rajeshri Ghosh sir asking that is there any indirect relationship between exosome and insulin secretion from pancreas?
Yeah, there should be, because if they both are there in the extracellular region, means the external environment. So if either way you can see that insulin, where the presence of insulin helps the pancreatic cells for more EV biogenesis, and probably if that is correlated with any disease conditions or recovery conditions, that can give you some indications in presence of insulin if they instigate the EV biogenesis or exosomal biogenesis from the source cells. So there is a very likely that it is possible.
Okay, next question from OP Singh sir. What is the therapeutic dose and half-life of exosome cargo in vivo?
Well, it depends on the type of the exosomes and what cargo we are loading. So exact value I cannot give, but exosomes as such, without any delivery cargo, if in vivo we give, then uptake process is, if it is given in vivo, uptake process is 5 to 6 hours.
Okay. Next question from Mansi Mandal. Do all prebiotic work the same way? How long should one take this?
Yes.
Do prebiotic have any side effect?
That's a very good question. In fact, one of the slide that I have, I'll just quickly show that slide. So this is a major question, that how long the probiotic bacteria stays in our gut, either it's a prebiotic or probiotic. So we need to know the gut transit time of each of these bacteria, particularly if you're working with prebiotics or probiotics. So I believe this is the slide. So if you can see that slide, so here this for example, this is lactic acid producing bacteria. When you inject into the mice orally delivered, and you can monitor, one can monitor using in vivo imaging system if those bacteria can express some fluorophore proteins or some reporter proteins. So for us, the lactic acid bacteria, it's a non-commensal bacteria. The gut transit time we calculated from dosing to is just 3 hours. So imagine we are either taking many of those probiotics without knowing the dose, or we are overdosing ourselves.
Okay, participant, you may ask question directly to sir.
Yeah, hello, sir. I'm Dr. Prajit Nambiar from Mumbai University. And first of all, thank you so much for covering this topic. This has been lately my interest of study, and mainly because I have been working during my PhD on protein synthesis under nutrient deprived conditions from bacteria. And just where I was doing an SEM to observe the morphological changes, I found these extracellular vesicles coming out of the cells. And my organisms were actinomycetes. And I found there are less papers about actinomycetes and they are producing extracellular vesicles. So my question is, like, if there are still less organisms explored on which are producing extracellular vesicles. So is it like every organism bacteria can produce extracellular vesicles, or are there limitations?
Yeah.
And if there are like many organisms producing, then what are the genetic factors that would be common in them, which is making them produce these EVs?
So see, means as I discussed that it's a canonical end product. It's a physiological process. So the release of the OMVs is a natural process. You can expedite by using tweaking the environmental factors like stress and the pH and the temperatures. But OMV release from the bacteria is a different pathway. Means gene, there are a lot of proteins or mechanisms associated with OMV biogenesis, and which are different from gram positive to gram negative. Even within the gram negative, if you see the mycolic acid presence in the mycobacterium has a different pathway or different strategy how to release them. But it is not necessary that all the bacteria will produce the similar quantity of the EVs. It cannot be said that because of their peptidoglycan or the other component on the cell wall, and whether sometimes they have become drug resistant, for example, then utilizing some drug to destabilize their surface may not work. So Actinobacillus, for example, and the other bacteria, if you want to get the more output, you need to know the physiology of the bacteria and what are the factors which generally affect the bacterial growth, proliferations. So if one of those factors, if we can optimize, like of course we are not going to kill the bacteria, that's why I mentioned we have to titrate those bacterial conditions in environmental stress or others. And in terms of biogenesis, there are sex-dependent pathways are there. So it's many pathways means so they are all associated. Even I mentioned that bacterial type 6 secretion system is one of the major gene we found. So we are trying to see whether this secretion system has any role in OMV biogenesis. Then the retrograde lipid assembly transport actually from the outer side to the inner membrane. So that's the normal process. So if you modify that lipid asymmetry, the transport of lipid asymmetry, then there will be a change in the vesiculation process. So you can make a non-vesiculating bacteria in a vesiculating bacteria. So for example, MLA pathway for the gram-negative bacteria is a very known pathway where you have many scopes for mutating MLA A, B, C genes.
Okay, next question. Please ask Dr. Arunima Datta, ma'am.
Yeah, thank you, sir. It was a very insightful talk. I just want to ask a simple question, sir. I'm from Chhattisgarh. I'm presently working in Chhattisgarh. Is it possible to use sonic disruption method for removing the peptidoglycan layers from the gram-positive bacteria? Has it been applied?
So this is a harsh physical stress to the bacteria. So, and we do not want the vesicles to lose its shape, morphology, because for those who work with nanoparticles, you know that the vesicular structure retention is a major factor for many purposes, like the size matters for I would say that selective what I forget, a freight is something that can go for the diameter of the vessels that matters. So sonication, into my opinion, sonication would not be a good approach because, and also you want to have the peptidoglycan to give the membrane strength. So disruption, because most of the vesicles, as I showed for the gram-positive, they retain the peptidoglycan. That means the peptidoglycan keep the strength of the outer membrane. If they don't have outer membrane though, the outer layer of the vesicles, so that we can have self-life and the vesicular structures.
Okay, next question, Chandan Singh, sir. You may ask your question.
Good evening, sir. This is Chandan Singh from Department of Biochemistry, BHU. Sir, I'm doing clinical metabolomics. I have a question. If I'm planning to work with extracellular vesicles, but how is it to scale it up? Like if normally we get it in very low concentration, be it for metabolites or proteome, but I want to use it for both proteome and metabolome. But how is it to produce it at higher level?
So it also depends on the source bacteria, like whether you are using gram-positive or gram-negative bacteria. First thing, so if it is a gram-negative bacteria, then you can have more of the OMVs in the medias, and concentrating is there are concentrating device, so you can concentrate a larger volumes. You can do fermentation for the scale up, but I believe the fermentation is too much to go. So larger volume, before even go for further concentrations, you have to do further pelleting. You can have one step for concentrating the culture supernatant, like simple method using concentrators. And there are few, in the market available, the concentrators. You can reduce the 1 liter volume to 100 ml, but you don't need to, make it 1 ml. So then the thickness of the media will not help for the further ultracentrifugations. So it's not, and also you can work on the bacterial. If you understand the bacterial growth curve, at what stage they are mostly, OMV exfoliation happens. If you identify that stage, then you can always collect the bacteria at that stage during their growth profile, growth curve. Either it's an early log phase or exponential phase. So that can also be cross check.
Thank you, sir.
Thank you.
Okay, thank you, sir. Any other questions?
Yeah, I have one more question, sir.
Sure.
So, do these extracellular vesicles, once they come out from the bacteria, does it fuse back to the same bacteria?
It's not possible.
Like, even in the case of gram negative?
Oh no, I don't think, because bacterial uptake process is different, right? Bacteria cannot uptake these bigger size molecules because they can release, but they have no channels to get those bigger molecules inside.
So it cannot fuse the cell membrane, like, since in the case of gram negative, because it has less peptidoglycan layer.
So confidently, I cannot say at this moment, but that is very unlikely that they will again refuse, because once they're in oil in water emulsion, those vesicles are kind of now in the extracellular media, right? So they are surrounded by the water, and then the lipid, whatever the structure. So that interface, water interface, will not allow them to fuse, and both will be negatively charged. OMB is negatively charged, and because of the LP is negative. So although, as I said, I'm not very sure, but what I understand based on that, that's my explanation, that they cannot reuptake or refuse with the.
Okay, because I was just wondering if, like, organisms are using these extracellular vesicles to transport DNA across, like, for antibiotic resistance or so, then it has to go from one cell to the other cell, maybe of the same species or say.
So cell-cell communication can happen even receptor mediated. I mean, they can bind to, if they have the corresponding, the receptors, ligand basis, but they cannot uptake because they do not have the bigger channels to get uptake. So that information, I don't think they will use as a genetic transfer materials.
Okay.
Okay, thank you very much.
Thank you so much.
Thank you very much, sirs, for answering all the queries of our participants. Now this session is over. Sir, if you want, you may leave now. Thank you very much again for your time and for your insightful presentation. Thank you, sir. Dear participants, our assistant coordinator want to talk all of with you for regarding tomorrow sessions.
কি আছে শুভদীপ? না না, এই আছে, আমাদের অজন্তা যায়নি।
Good evening, everyone. Mr. M.R. Ramesh, if you are here, please respond. Mr. M.R. Ramesh. Okay. So maybe there is some issue. Okay, so as per the latest developments, we will be able to share the e-abstract with you all by tonight, and the list of the presentation slots by tomorrow morning session. So thank you all for being present in the day one of this refresher course. Hopefully day one was packed with information and various kinds of new knowledge, and hope it was enriching. Since it is a 12-day long program, I will not take up any more time. Thank you all. See you again tomorrow at 10:30. Thank you.
Thank you, ma'am.
Thank you.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.